Doctors, we are live. You can start the session.
Good morning, friends. It's actually a great, delight to see all of you on a Sunday morning. And this is none other than the very important meeting, which is the Tnoa Connect series. As you all know, the theme for this year for the Tamil Nadu Ophthalmic Association is Tamil Nadu Smiling and Tnoa Shining, and we are doing exactly that for the past 5.5 months. As the president of the Tnoa, I would like to welcome you all for this very, exciting webinar on oculoplasty and organized in association with the MNI Hospital. This Tnoa Connect series is a new concept which we started way back in September when I took over as the president of the Tamil Nadu Ophthalmic Association. And this Tnoa Connect series connects all the major institutes and for every subspecialty in ophthalmology on the last Sunday of every month between 11 a.m. and 1 p.m. IST. And to start with, we are none other than RAO GOH in September on mucormycosis. And in October, we had with Shankar Netralia on pediatric ophthalmology. And in November, we had with Agarwal Eye Hospital and challenging cases video symposium. And December, we had with the Eye Foundation on cornea and refractive surgery. Are you able to hear me?
Yes. Yes, sir. Yes, sir.
And January, we had with Rajan Eye Care, again on cataract and IOLs. And of course, in February, now we are having in association with the MNI Hospital, which is a postgraduate institute of ophthalmology in Chennai, and on oculoplasty. And Tnoa has got many other initiatives as well. The Tnoa ARC PG Catalyst, which has been conducted every second Friday of every month, supported by the Milmet, which has become very popular as well. And of course, the Walk the Talk series on every first Saturday with the luminaries of the Tamil Nadu Ophthalmic Association. This week, that is on March 5th, we are having the Walk the Talk series with none other than Dr. Arulmozhi Varman of Chennai. And we're looking forward to having you all for that as well. All these programs of Tnoa, apart from the World Sight Day, we have the Publish and Prosper, the Ophthalmic Photography Contest, and the National Quiz, and many other programs also, received wide appreciation and support from all the delegates across the world as well. And it's become very popular, and each of these symposia are being attended by none other than more than 2,000 delegates on the YouTube and the Facebook of the Tnoa. So, as the president of the Tnoa, I have great pleasure I have the privilege. I'm very blessed to have a fantastic team with me. It's like the Indian cricket team now, and we have a very good team. And the president-elect is none other than Dr. Ramakrishnan, Vice President Dr. Nirmal Frederick, Secretary, Dynamic Secretary Dr. Madhavan, and Treasurer Loganathan, of course, the members of the Managing Committee, and other, the ARC Chairman, the Editor Journal, everything. The entire team has been a very good team, and we have been gelling very well, and we have been doing a lot of academic and support academic programs as well, which is increasing the knowledge of all the practicing ophthalmologists as well as the postgraduates and the residents across the country. And again, I would like to thank here Dr. Pratibha Nivian. Dr. Pratibha Nivian doesn't require any introduction. She is one of the very competent oculoplastic surgeons heading the MNI Hospital, and as far as oculoplasty and orbit is concerned. And she is the one who's been coordinating this entire Tnoa Connect series for that. And of course, Dr. Atik, again, who doesn't require any introduction, a member of the management committee of the Tamil Nadu Ophthalmic Association, and also chairman of the scientific committee of a very successful Madras Icon, which we had in September last year. Dr. Atik and Pratibha are coordinating this entire thing, and I think Pratibha will be moderating this session. And along with that, co-moderator is Dr. Atik Sheikh, who will be taking care of this session. And we have got a fantastic galaxy of speakers, the panelists from across the country, and the top stars, I would say the superstars of oculoplasty. I'll be failing in my duty if I don't mention the master class which is there about 2 weeks back on Oculoplasty, which is a Tnoa ARC PG Catalyst Masterclass by none other than Dr. Sendil Nathan and Dr. Usha Kim on ptosis. And it is really a fantastic masterclass, and it was widely appreciated by all the delegates and all the postgraduates and even practicing ophthalmologists. It is one of the best masterclasses we have ever seen in the history of TNOA. And I hope to, take it forward, get a help as well. And with your support and blessings, I'm sure we'll be able to do that and make sure that TNOA is at the top of the table as far as the state ophthalmic associations are concerned. And with these few words, I would like to ask our dynamic and always ever-inspiring President-elect Dr. Ramakrishnan of Aravind Hospital, Tirunelveli, to say a few words. Dr. R.K. sir.
Thank you, President. Respected President, the Secretary and Vice President, Treasurer, and office bearers, and today's webinar on Oculoplasty, the wonderful speakers, panelists, and the organizers. Very warm good morning to all of you. First of all, I have to thank Dr. Pratibha and Atik for coordinating this wonderful session on oculoplasty, mainly involving the lacrimal and lid surgeries. And of course, the today's webinar is no need to say, as having a wonderful collection of speakers from our own state and also from our all over India. That's wonderful speakers like Dr. Usha, Senthilnathan, Yogeshwari, Dayakar, Pratibha, and Vikas Menon. There are so many people. So really, it's a wonderful feast for those who love oculoplasty. I'm very happy to say that I was also an oculoplastic surgeon once upon a time. That's long back, about 25, 30 years back. But now it has changed so much in each and every field, not only in lacrimal surgery, but also cosmetic also. So definitely it will be a wonderful feast for all of us. And I'm very much thankful for the organizers and also the TNOA President, Dr. Mohan Rajan. Thank you, Dr. Mohan Rajan.
Yeah, thank you, sir. It's always very inspiring and motivating to hear you. And I think since Dr. Madhavan is not available, he's held up in some work. And Dr. Nirmal Frederick is there, our Vice President. I request Dr. Ravi Shankar, who is a member of the management committee, to say a few words, and then we'll hand over the proceedings to Dr. Pratibha and Dr. Atik.
Thank you so much, President, for giving me the opportunity. It is indeed a pleasure for me over here to welcome you all on this special day, and lots of work has been put in by Dr. Pratibha and coordinated so well by Dr. Atik, as rightly said by the President as well as the President-elect. So it's time for us to sit back and relax and enjoy the oculoplasty session, and by the masters and the stalwarts from the entire country. And thanks a lot, the entire faculty, for accepting to be the speakers and the panelists today. And it's indeed a proud moment of Tamil Nadu Ophthalmic Association. Thank you once again. Over to the President to go on with the session. Thanks a lot.
Thank you, Ravi, for the nice words. And Dr. Pratibha and Atik, it's all yours.
Atik?
We'll go ahead, Pratibha. Please start.
Yeah. A very good morning. I would like to sincerely thank TNOA committee and especially Mohan Rajan sir for his lovely initiative for all these academic work, and for giving us this opportunity to to host this webinar on update on oculoplasty. So the topic for today is update in oculoplasty, particularly lid and lacrimal. So we thought we will include simple topics which will be useful for both general ophthalmologists as well as practicing oculoplastic surgeons. So we have video-based presentations of simple oculoplastic procedures today. And we have included eminent speakers from all over the country who are very good in this field. Without wasting much time, we'll start the session. I would like to invite the panelists for today's session. First, I would like to invite Dr. Ravindra Mohan, sir.
Good morning. Good morning, Pratibha. Good morning,
Yeah.
Dr. Mohan.
I'm just opening up my presentation. So Ravindra Mohan sir is one of the senior orbit oculoplastic surgeons who headed the department in Shankar Nethralaya, and now he's currently with the Global Multi-Speciality Hospital and is the director of Eye Care. He holds the honorary adjunct professor post in Tamil Nadu MGR Medical University, and his area of interest is minimal incisional orbitotomies. We welcome you, sir, for sparing your time to share your experiences and knowledges in this particular field. Next, I would like to welcome Dr. Vikas Menon, Dr. Yogeshwari, madam. Sorry, Dr. Vikas Mehan, sir. He's a very experienced, soft-spoken oculoplastic surgeon who did his PG from Sri Gangaram Hospital and did his fellowship in LVPI. He's currently the consultant of oculoplasty in Arvind Eye Hospital, Chennai. He has got a lot of publications and he's reviewer in IGO. We welcome you, sir. And next, I would like to welcome Professor Yogeshwari, madam. She is one of an excellent teacher, currently the assistant professor in Orbit Oculoplasty Department, RAO GOH. She has done many publications in index journals and has done many presentations, and she has trained many PGs under her. We welcome you, madam. So,
I am professor and I am heading the orbit now.
okay.
Professor of the.
Yes, sorry, ma'am. And now I would like to welcome the first speaker of this session, Dr. Vidya. Vidya ma'am is a very calm, composed oculoplastic surgeon from Coimbatore. She completed her fellowship in Arvind Eye Hospital under Dr. Usha ma'am, and she is currently practicing in Eye Foundation, Coimbatore. We would like to hear from you about external DCR, ma'am. Welcome, ma'am.
Pratibha, so Yogeshwari will be very soon become the director of RAOGOH.
Oh, I'm sorry, ma'am. Happy to hear that, ma'am.
Wish her all the very best.
Yes, ma'am.
Thank you,
Pleasure to
sir.
have Yogeshwari on this panel.
Thank you, sir. Thank you.
Thank you, Dr. Pradeepa, and thank you very much, Dr. Mohan Rajan, sir, for having me here. And a very good morning to one and all. I'm going to be talking about tips and tricks of external DCR. World over, the conventional DCR is still the gold standard technique with a very high success rate of about 95%. The principle here.
You have not shared it.
Pradeepa?
You have not shared the presentation.
Is it?
Yeah. Please share the screen.
I have shared actually. 1 second.
It's not coming.
Is it visible now?
Now it's better. Yes, correct.
Yeah, okay. I'm so sorry. Okay, so I'll be talking about external DCR. So the principle of external DCR is that we are creating a low resistance pathway from the nasal mucosa and the lacrimal sac mucosa to the nasal mucosa through a patent ostium. That's the principle of this surgery. The goals of the surgery is to eliminate tear and mucus retention and also to prevent the enlargement of the lacrimal sac, such as an acute dacryocystitis or a lacrimal abscess. So the workup includes preoperative assessment, anterior rhinoscopy, and a systemic evaluation to have a successful surgery. So the preoperative assessment should have a good clinical assessment regarding the site of obstruction. The site of obstruction can actually be from the puncta to the canaliculus to the nasolacrimal duct, anywhere in this lacrimal apparatus. This can be identified by a simple test like a syringing or fluorescent dye disappearance test. Also, we need to rule out conditions like canaliculitis, which can actually mimic like sac obstruction, and also the other coexisting lid abnormalities like paralytic ectropion or scarred, which is running right across the face, causing medial ectropion as well for a successful outcome. Also, we need to have an anterior rhinoscopy, which will help us identify conditions like septal deviation or atrophic rhinitis, or sometimes mass lesions like this, which requires different management and involves different specialty as well. And we need to have a thorough systemic evaluation, which would help us assess the general status of the patient, the comorbid conditions that has to be addressed before venturing into a surgical intervention, and the immune status of the patient. These days, we also need to do RT-PCR, X-ray chest, and ENT procedures, history about ENT procedures, and intake of antifungals in this pandemic situation as well. We need to spend quality chat time with our patients with regards to explaining the procedures and advice according to the general status, like stopping the anticoagulants just 5 days before prior to the surgery. And we have different options and success rates, and this has to be discussed with the patients. On the day of surgery, we need to have a good light source, set of instruments that is required for the surgical procedures, a suction apparatus, all these ready for a successful outcome. And again, pre-anesthetic medication, I give injection paracetamol 1 gram IV as an infusion, and this works really well as a post-operative pain medication as well. And lignocaine jelly in the nostril or oxymetazoline spray just before the procedure. And intraoperatively, we need to monitor BP throughout the procedure. So the procedure, the external DCR can be done under local anesthesia or general anesthesia. Local anesthesia in most of the adult patients, a combination of infiltrative block, infraorbital block, and infratrochlear block is usually what we do. And it's the lignocaine with or without adrenaline is the drug of choice in blocking. And once we are done with the block, we go ahead with the nasal packing, which is a very important step. Here we use a medicated gauze, which is soaked in lignocaine and adrenaline and packed into the nasal cavity with successive loops. The direction of packing has to be posterior and superior, and it has to reach the middle meatus, which is the site of our osteotomy. So that is when we get adequate nasal packing, and it helps in hemostasis as well. Once we are done with the nasal packing, making the skin incision is the next step. Here, there are variety of skin incision. What I'm exhibiting now is the straight incision, which we do it from 10 millimeters from the medial canthus. Care to be taken to avoid the angular vessels, and the length of the incision can be around 10 to 12 millimeters. So once we are done with the skin incision, we go on to the next step, which is the separation of the orbicularis and the MPL retraction from the periosteum. Mind you, it is only the separation of orbicularis, and it is only the blunt dissection of the orbicularis, and we usually retract the MPL from the periosteum. So this is the MPL, and this is the angular vessel. Care to be taken to avoid the angular vessels, damage to the angular vessels. And once we are done with the skin incision, we go on to the osteotomy. We have to keep the anatomical variations in mind, and the superior limit is just above the MPL. That is where we go ahead. And what we should not do in a case of an osteotomy is this pulling and shearing movement. Because these type of movements, this is done just for a demonstrative purpose, and once we are doing this movement, it tend to cause crack fractures, and it can result in complications like CSF rhinorrhea. So that has to be avoided. Once we are done with osteotomy, then the next step would be creating the lacrimal flaps. It is the lacrimal probe that we use to tend the sac, and we make a head-shaped incision. We create 2 flaps with anterior part and the posterior part. I just take 1 more minute. I'm done almost. The posterior part of the sac can be removed, or it can be sutured separately. The same thing can be done with the nasal flaps. We make a head-shaped incision in the nasal mucosa, and again a large anterior flap is taken. A posterior flap can be again removed or sutured according to the difference. It doesn't have any statistical difference in the success rate. And once we are done, it is the mucosa to mucosa anastomosis that helps in the formation of successful anastomosis. So edge to edge anastomosis is what we need to create. Can be done with an interrupted suture or a matrix suture. And once we are done with the suturing of flaps, the final step include the anchoring of flaps to the muscle, and then the skin closure with a simple interrupted sutures. So post-operative care includes avoiding hot fluid and intake for a couple of days, and we need to advise not to blow the nose oral and local antibiotics for about 5 days and along with nasal vasoconstrictors. Intubations are indicated in selective cases as indicated here. And hemostasis is the key for a successful DCR. Always anticipate bleeding in DCR. Along with our meticulous surgical steps, we need to have cautery, packing, and gel foams with our armamentarium. And to conclude, success depends upon excellent preoperative workup, meticulous surgical steps, and of course, good assistance. Thank you very much.
Thank you very much, ma'am. It was a nice presentation, and you stressed the importance on doing a pre-op nasal evaluation, which is very important. Otherwise, we would miss even tumors. And ma'am, one question I would request Ravindra Mohan sir to give his comments and his opinions first. Ravindra Mohan sir.
Is he online?
Yes.
Yogeshwari ma'am, or yeah.
Yeah.
Madam, in case of acute diagnosis status, how long will you wait for you to plan for external DCR?
Ma'am, actually, it is the inflammation has to subside before we intervene. So that is one of the drawbacks of external DCR. So I usually give oral antibiotics for a couple of for at least 1 week, and then wait for another week for the inflammatory changes to come down, and then proceed. Basically, I wait for about 2 weeks before proceeding into
2 weeks time.
Yes.
Vidya,
Yes, sir.
about the options of general anesthesia versus local anesthesia. There's
Yes,
a
sir.
huge difference in the practice pattern if you go from region to region and nation to nation. So what is your profile of patients who you would perform under general anesthesia? I think in this country, the vast majority of operations are done under local anesthesia, and rightly so. But what would be your patient who is better done under GA than under FA?
Those patients where I require, I expect a lot of manipulation, like in secondary nasolacrimal duct obstruction, where my surgical duration might be prolonged, or where I anticipate some difficult intubation or something, then those cases definitely I would prefer general anesthesia as compared to local anesthesia. Even those cases I do under IV sedation, and where there is a language barrier. Some of our patients come from Bengal, and where they cannot understand Tamil, and I can't have an interpreter inside the thing. In those cases, I discuss with them and have general anesthesia. Apart from that, most other patients I do under local. Pediatrics, of course, we have to do under general anesthesia.
Traumatic, post-traumatic, do you do all the post-traumatic under GA or some of them?
No, sir. Where there is an extensive bony deformity, and where we anticipate some kind of increased surgical duration, that is where I prefer having general anesthesia, sir.
And revisions?
Revisions most commonly we could do under local. If it is my own revision, obviously I'll do under local. But if it is somebody's like from other institute, or where they had a difficult surgery pre-operatively, possibly I will consider general anesthesia.
I think that's a fair way to proceed with DCR. Anesthesia for DCR.
Yes.
You mentioned about IV paracetamol. Did you do you routinely use IV paracetamol for all the patients?
Ma'am, to start with, I was actually using injection Fortpin and Finargan. Like maybe 10 years back when I started here, then I used to give injection Fortpin and Finargan. Then later on, I realized it doesn't give much of post-operative analgesia, which again requires some more injections. Then when I discussed with my anesthetist, and this option of giving IV paracetamol is what we are doing now. It works really well. Intraoperatively, we start this infusion, 1 gram IV, doesn't have any effect on the bleeding time. So it helps in postoperative analgesia. 4 to 5 hours, patient is really happy, where we can start oral analgesics after such time. So routinely, I use IV paracetamol these days, madam. And it's really helpful also.
Do you use mitomycin C or silicon tube intubation for external DCR?
Silicon intubation, yes, madam. Wherever I mentioned those indications, like pediatric cases, I routinely use silicon intubation. Secondary nasolacrimal duct obstruction, also I use silicon intubation. Or whenever there is an intraoperative complication like a loss of flap, that is when I prefer using a silicon intubation. Mitomycin C, somehow I don't prefer or using it on a routine basis, but where there is an extensive scar in case of revision surgeries, yes, I've used mitomycin C. So other than those revision surgeries, I'm not using mitomycin C on a regular basis.
Okay. I think Preeti ma'am will be elaborating that in her talk. And one question is that I have a question, ma'am. We do see patients with septal deviation, mild and severe. So when what would be the severity of septal deviation when you would refer to an ENT colleague? Would you refer even a mild septal deviation, or how do you grade that?
When there is a septal deviation, that is one factor that is going to affect our surgical outcome. And those are the conditions where endonasal DCR really plays an important part. So when you have different choice of surgical like external and endonasal procedure, and you have a septal deviation as well, what I do is that I refer that patient to a ENT consultant, have an evaluation done. And then if it is not a contraindication for an external procedure, I go ahead with the external procedure. If it is if that patient is a candidate for endonasal, then we go ahead with endonasal DCR along with septoplasty. Yes.
Okay. Vikas sir, any comments?
Well, I think Dr. Vidya covered everything very nicely. Only a few comments that basically, you see, you have to identify what is important in these patients of DCR, routine DCR cases. I'm not going into complicated DCRs. Number one is you should have proper anesthesia, adequate anesthesia, because if the patient is in pain, it will lead to increased BP, it will lead to increase bleeding, and your view will get obscured and the surgery will become difficult. So start with every step. So anesthesia is very important. Then a good light source is very important. If you don't have a good light source which is getting focused light into your area of surgery, then it is better to get a headlight. Now, I use headlight. I've been using it for years, and I find it very, very useful for all DCRs and all orbital surgeries. It gives you a very focused beam of light at the area where you're looking at, and it helps you to identify any bleeding points, any point where you need to pay more attention, which is otherwise sometimes not possible with if you just have a diffuse external light source. Second thing is, next thing is that, you should be prepared to look for the common points of bleeding where you can anticipate the bleeders prior, and take care of them before you actually jump with your knife or your instruments in that area. The common sites of bleeding, we all know, angular vein, Dr. Vidya covered. Then you can have sutura notha bleeding. Then you can have a bony ooze from your ostium bone, and then you can have the mucosal bleed. And if perchance your anatomy is little distorted and you are not very well versed with the anatomy, you can even go more posteriorly and cut one of the ethmoidal vessels, which can be a really, really problematic situation. So try to avoid all those areas which can lead to complication and make your surgery more difficult than a routine surgery. So I think all these points, if we take in account, it will make our journey smoother and our procedures smoother. One difference I found with Dr. Vidya's technique a little bit is that I routinely use mitomycin C, and I routinely do not use intubation in my patients. Because sometimes I've seen that, just the intubation tube used to cause granulation tissue, and that would be the cause of failure of DCR in some of the patients. So if your ostium is at the correct site, the site of ostium is very, very important. You have to pass a probe through the canaliculus, and you have to see that your ostium is at the site. More than the size of the ostium, it is the site of the ostium which is more important. And if your site is proper and your probe is lying freely in the ostium, then you're at the correct site. So I think that summarizes the external DCR in my view. And thank you very much.
Valuable points, sir. The
Wonderful,
site.
wonderful.
Yes.
Are we on time, or
Yeah.
can we sneak in? I think it's something, DCR is very scary surgery for beginners and for many of us early in our career. And I still see patients whose surgery has been abandoned, or, close up in panic, and then finally the patient ends up with us, and we have to do it in a more difficult way with GA and all that. So I'd like to ask Vidya and even the panelists, what are the essentials in your operation theater before you do a DCR? Because I mean, let's assume that most of our ophthalmologists do cataract surgery, and DCR is an occasional surgery for them. And DCR, ideal state, can be done by comprehensive ophthalmologists and done fairly well, except the difficult ones. So what all should be there in the theater, which you don't have to run for before you start an external DCR? I think that would be something which will be useful to a lot of ophthalmologists. So if Vidya could answer, or we could chip in.
Yes, sir. Actually, I never had this chance of closing it, but I had few patients who had torrential bleeding. At least two of them.
Not about you closing it, but somebody who's not experienced.
I understand.
They may not be prepared. For example, you need something to arrest the bleeding, and you don't have it, then you close up. So what all in the theater would help most people prevent such an event?
Got it, sir. Like at least 2 or 3 patients had torrential bleeding, and this made me think like what all I should have. And what I started after that is that all patients I started with Venflon. Before that, some patients may not have secured a line, but after that I started routinely starting with Venflon, connected to the machine, the monitor, and intraoperatively monitor the BP and pulse. That is something that I've started doing for all the patients, irrespective whether they are hypertensive, non-hypertensive, cardiac, or whether they do not have any systemic illness as well. So that is one thing that I've done. And this intraoperative infusions, these all started after having those pain. And as very well pointed out by Dr. Vikas, it's the pain that causes the problem most often. So we need to have clear analgesics with us. And tranexamic acid is one thing that sometimes help us. Like if you have torrential bleeding, then one such agent which could arrest is this. And rest of it, we should have gel foam and packing substance. That is also important. And cautery, working suction apparatus. Before starting a case, we need to check all these things, whether we have a working suction apparatus, and we should not be in search for things at the end of the thing. So connect BP apparatus, intraoperatively monitor all the vitals, and have these essential drugs in place. And these are sometimes in ward, actually I admit all those patients. So in fact, in wards, I give them at least 2-3 nasal packs also. So if it is required, they don't have to come down to the theater to get one nasal pack and go up and pack the nose. So these things are also to be taken care of when we have this. And if at all we have a patient with bleeding, then monitor BP, and we should have an ENT backup. Sometimes we may have to do a post-nasal pack also. So that kind of facility should also be available with us.
The only few things I may wish to add, because this pretty much covers, is Surgicel. Surgicel for intraop hemostasis. There's a brisk ooze, you can't localize it, you can't cauterize it, but things like Abgel, Surgicel are extremely important. And also in the very rare instance where you cannot get inside the bone, there's bleeding from the bone wax also. I make sure there's one bone wax. It has a very low cost, very long expiry. A couple of them should be in the theater. And of course, a good cautery and suction, and good light, without which you may not be able to find the bleeder or the source of bleeding. And a good friendly relationship with your ENT surgeon is sometimes needed, because some of the bleeding may be far too posterior, and you may need the help at any time. So I think that would be a useful list for anybody planning to do a DCR in any kind of setup. Thank you.
Yeah, so okay, the good discussion points and the take-home points as well to have the pre-op evaluation and the other points which were covered. Thank you, ma'am, and thank you, panelists. We'll now, for want of time, we'll move on to the next talk by Dr. Preeti Uday, ma'am. So Dr. Preeti ma'am is the director of DRR Hospital. I would say she's a superwoman in oculoplasty. She's an inspiration for many, including me. She has a wonderful setup, and her areas of interest is in navigation, and she has a lot of publications and has done many international and national presentations. We welcome you, ma'am, to give your talk on revision and traumatic DCRs.
Good morning to all of you. At the outset, I would like to say hats off to Dr. Mohan Rajan for his tireless effort in continuing learning through these series of webinars. And thanks to Dr. Pratibha to have put this program together. I will be speaking on traumatic DCR and revision DCR, which is a very challenging situation in oculoplasty. Some of it we have covered in the previous talk. So what has happened?
Initially, it got shared, but now we are seeing a white. Yes, ma'am, we are able to see.
Okay, so speaking on traumatic and revision DCR, starting with traumatic NLDO. So you can have trauma to the NLDO either iatrogenic or non-iatrogenic. Now, sometimes you're very aggressive with lacrimal probing, especially when you're doing orbital surgeries or nasal procedures or craniofacial procedures, and that can cause trauma to the drainage system. Or it can be non-iatrogenic, especially in trauma when you have mid-phase traumas like Leaford 1 and 3 fractures and naso-orbito-ethmoid fractures, or there can be a direct trauma because of laceration. So the important point is all these trauma patients, you must do syringing at the time of presentation and also on follow-up visits to detect late onset nasolacrimal duct obstruction. And the important investigation that I like to do in all these patients is CT-DCG, because the CT scan part of this scan tells you exactly where the sac is located because it can be displaced in these situations. And you can also see the associated bony fractures, especially you must look for a fracture of the cribriform plate in these patients. Can also look at the bones around which you're going to form the ostium, like the frontal process of maxilla, the lacrimal sac area, etc. And you can see the entire lacrimal drainage system also on the same scan. And preoperative nasal endoscopy is mandatory in all these trauma patients. You will get a lot of findings which you will miss if you don't do this. Now, the challenges in this situation is the anatomy is altered. Many times the sac is not in its normal position. I will show you such a patient. And you can also have a scarring and fibrosis, which is expected more after traumatic DCRs. And also associated canalicular blocks can be challenging, eyelid scarring. There can be presence of plates and screws in the area that you want to make the ostium. The sac can be small and fibrosed. And you can have intranasal factors like in this patient, the right side of the nose is completely smashed. And that has to be taken care of along with the DCR. Now, the important steps in DCR in these patients is you must make larger incisions. Your exposure should be good. Preserve as much as orbicularis as possible because the orbicularis is already scarred and you can have pump failure in these patients. Make large osteotomies because you expect scarring post-operatively. Also maneuver very carefully around the impacted bones, plates, and screws because if you are literally aggressive, the crack can extend up to the cribriform plate and cause CSF rhinorrhea. I routinely use mitomycin C in most of these revision or traumatic DCRs, especially if you have scarring and bony canesis in that area, and intubation if needed. Now, in spite of our best efforts, you still can have inadequacy because of pump failure and eyelid scarring. So like you see in this patient, he has a left lacrimal mucocele. You can see the mucocele on CT-DCG, and you can see beautifully that the dye is going in the right NLD, but not going in the left NLD in the coronal as well as oblique views. So CT-DCG gives you very useful information. Now, sometimes you have patients like this who require multiple procedures. This patient has enophthalmos, he requires orbital reconstruction, he requires bilateral DCR, he has acute dacocystitis here. He also requires soft tissue augmentation and telecanthus repair. So here you can see the patient has severe enophthalmos. You can see the fractures on the CT-DCG. Here the fracture is seen clearly of the nasolacrimal canal on the right and the left side. And the challenge in these situations is how do you sequence your repair? So most of these cases, I like to do the orbital reconstruction along with your DCR because you have all the exposure available. You're already opened for your fracture repair. You can plan your plates and screws in the location which is away from the ostium. All you need to do is an extra 20 minutes to establish the anastomosis. So it is better to combine the two, do the orbital reconstruction with the DCR. Same we have done in this patient, we have done the orbital reconstruction using navigation and done the bilateral DCR in the same sitting with silicone intubation. You can see the tubes here in both the sides. And then the next stage was the soft tissue augmentation by dermis pad graft to support his lower eyelid along with the rhinoplasty. And then you wait for the rhinoplasty to heal before you do a transnasal wiring. So this is the DCR ostium on both the sides. And here you can see that after the soft tissue augmentation, his eyelid position is okay. And then this is the position of the telecanthus at the end of the surgery. Now, this is on table appearance. Now, another patient here who has a naso-orbitoethmoid fracture and an NLDO. Again, I have combined the two. Here is the fracture repair. I planned the plate little anteriorly so that I can make the ostium posteriorly, and also done monocanalicular intubation because his lower canaliculus. I used mitomycin and heme 0.2 milligram per ml for 3 minutes, and I leave the intubation for 4 to 6 minutes. Now, Pratibha wanted me to show you how intubation is done. So this is how I use a bicanalicular silicone intubation from Precon. I first pass the probe from the punctum into the common canaliculus and bring out the probe by using a curved artery forceps from the nose. Be very careful to do this atraumatically because if you cause scarring at the common canaliculus, your procedure will fail. So this is one intubation, and now you go to the upper canaliculus system, do the same thing and bring the tube out from the nose. Make sure that both your tubes are coming out from the common canaliculus. You can see the common canalicular opening clearly when you're doing the magnification. I'll just take an extra minute. And the tube in the nose is then knotted. Now, this is not a DCR procedure, but I just want to show you how the tube is knotted. So these knots are taken at the nostril. Make sure that this loop and the medial canthus is not too tight. So I ask my assistant to hold the loop there. And then you make these knots. And once you cut the knot, the tube will retract inside. Now, coming to revision DCR, I think the most common cause of failure is inability to open the sac completely. If you make an opening superiorly on the sac, the inferior part of the sac will collect the mucus, and you will have a positive rhoplus, but a patent syringing, which is the typical sum syndrome, which is the commonest cause of failed DCR. Also, the size of the ostium matters. Make a large ostium because ostium does shrink with time, and taking care of the canaliculus. So this is what I want to say today, that in failed DCRs, to prevent it, you must open the sac completely, and that is what I'm showing here. The opening of the sac, when you're doing, you must have your lacrimal probe inside to safeguard the canalicular system again. And make sure you go right from the fundus to the opening of the NLD. Make nice big flaps. And similarly, you make big ostium so that you have a big anterior nasal flap. Here I have kept both the flaps intact just for video recording purpose. I'm also showing the posterior flap suturing. But once you have done that, you then suture the anterior flap. I take 3 sutures on the anterior flap, so you can imagine the flap size is quite big. And keep the probe in place even when you're suturing the flaps. So this is the first suture on the anterior flap being sutured to the sac flap. See, the probe is in place so that your bite also doesn't go through that tissue. And then I anchor the flap to the orbicularis, which Dr. Vidya had already shown. And I do not excise any of the orbicularis. You retain as much orbicularis as possible. So I close the wound in 2 layers, first the orbicularis and then the skin. So this is the third suture on the anastomosis. And then you anchor this flap to the orbicularis. So this is the bite from the orbicularis. So these are the steps that you take in cases of failed DCRs. Most of the time, you are able to do these procedures under local anesthesia. Like I said, if you have bony calluses or if you have plates and screws in the area of the ostium, then I prefer a GA because sometimes you need chisel and hammer, you need a drill. The bone is too thick for you to make an ostium. So here I close the wound in 2 layers, orbicularis and then the skin. Thank you very much for your patient hearing. I'll be happy to take any questions. Thank you.
Thank you very much, ma'am, for the lovely presentations with videos. And you insisted very well about the importance of CT DCG in case of a traumatic DCR. Ma'am, one short question, like what would be the indication of primary DCT in a traumatic NLD in your opinion?
So most of the time, I don't prefer to do a DCT, except sometimes when you have trauma, severe orbital bone fractures, and also you have lost the globe, you have a thicical eye. In those cases, sometimes I like to use a mesh for the naso-orbitoethmoid fracture repair. In most cases, maybe, and most of the time they have canalicular problems. So if they have a bicanalicular block, they have a scarred sac, and you want to reconstruct using plates in that area, I would do a DCT. But otherwise, most of the cases I would prefer to do a DCR.
That decision you will take by seeing the CT-DCG, ma'am, the scars and fibrosis.
And sometimes you know it's not going to work if your eyelid is too scarred, if your canaliculi are too scarred, you know DCR may not work. Those cases you can do a DCT.
Fine. Request the panelists to comment upon the revision and traumatic DCR.
Yeah. Just one question. In a traumatic DCR, unlike routine non-traumatic, let's classify, we are always very worried about removing the tube, which we did, right? Because once the tube, if after removing the tube, the ostium closes up, then we need to revise it under GA once again. So how long do you try and keep the tube in these patients? And how do you decide when to remove it?
Yes, sir. So I feel the tube doesn't maintain the patency of the ostium. It is especially for canaliculus to maintain the common canaliculus. Yeah. And most of these patients, I feel 4 to 6 weeks is enough for us to maintain the patency. So that is when I remove it. The success basically would depend on the size of ostium and how you have handled the canaliculus system intraoperatively, I would say.
Right.
I recently saw Lakshmi Madam's message in WhatsApp today morning about the marble in mucosal lining in DCR. We routinely anastomose only the anterior flap. So in case of traumatic and revision DCRs, would that increase the success rate? I do not have any experience. Panelists and experienced people can give their inputs about that. Even Lakshmi ma'am can give her.
Hi, thanks for bringing it up. I've struggled over the years with DCR surgery. Can you hear me?
Yes, ma'am.
I really struggled. Like in the 90s, I used to do a lot of 93, 94, I used to do a lot of DCTs because I was not good in anastomosis. And later on, when I learned my nasal endoscopy, that is sometime in 95, 96, I found that my external DCRs were improving. I started doing good external DCRs. And I tell you, if you keep the tube, whatever it is, when it's on the bare bone, even endoscopic DCR is a great surgery. But you should realize you're burrowing like a rat and leaving the bare area there and allowing it to heal by secondary intention. If you have mucosa, nothing like it. Last week, I anastomosed. I did a DCR for a girl 13 years after her trauma. She's a juvenile diabetic. She had issues on the table after the initial repair, like what Preeti has beautifully shown, then the later correction. But during the DCR part of it, the endoscopic DCR only she wanted. She's very fashionable. Of course, we respect that. But then you find that it is possible. It has to be painstakingly, you have to take your time and establish where the little mucosa, which will be left there, which will be enmeshed in fibrotic tissue. So I think you're all great surgeons. You know a lot of, you have all started with microscopes. You've done a lot of good phaco work. We didn't do phacos in those days, ICCs and ECCs to begin with. So I'm sure suturing the posterior flap is not difficult at all. And leaving that intubation on that posterior flap is far, far better than leaving that intubation on the bare bone. I really wish I had some fellow to work with me over the years as I've realized more to compile all the data. But this is again like traumatic optic neuropathy. If it comes to your child or your relative or yourself, I will take IVMP. I won't rely on the traumatic optic neuropathy study. So it's like that. Statistics may say that excising the flap is fine, but nothing like having the posterior flap also there. That's it.
Thank you.
Welcome, Lakshmi.
Okay.
Ayya, vanakkam.
Ayya, vanakkam. Amma, vanakkam.
Any other comments or will from the panelist?
I think one more point I forgot to mention is if you need a septoplasty, if there is a septal fracture or anything like that, you can also combine external DCR with the ENT procedure. There's no harm in doing a septoplasty. You need not resort to endo DCR if a septoplasty is needed. If you feel that you are going to get better result with your external, you can combine that with an ENT.
Sure. Okay.
Can I make one comment, Pratibha?
Yes, sir. Yes, sir.
I was doing DCRs long time back, about 20 years back. We were all pan-ophthalmologists. I was doing even lid surgeries before I started everything, cataract and retina and all that. But I'm just telling you that as Vikas rightly said, DCR, please don't burn your fingers. Many people have burned their fingers. They have lost patients because of hypotension, bleeding, and it's really a messy affair. And you should have a very good backup, very good anesthesia backup. Anesthesia should be there. Good monitoring intraoperatively, good monitoring of the BP is very, very important. Bleeding is also very important. You should know your plane of dissection exactly. And I think it's very important. Just don't take DCR very lightly. And this is a message I want to give all the delegates. Now I'm a general ophthalmologist. I'm just telling you, you're all specialists. You'll know better than me, but I'm just telling you, this is a message which I want to give everybody, all the other ophthalmologists also practicing. Because in the rural areas, still many people are doing DCR without proper, of course, they're doing under local anesthesia without any anesthesia backup. I think that's very dangerous. It's very, very dangerous.
Point well taken, sir. And actually, the speakers have also given their comments about stopping anticoagulants and raising the head end during the surgery when there is a bleeding encountered. And Chai had given about injection tranexamic acid. So yes, there are lovely points which I think all of us should have in the back of the mind when we are doing a DCR. With want of time, shall we move on to the next topic, or is there any comments?
Just one brief comment. Excellent presentation, Dr. Preeti. As usual, it was amazing to see your work. Really complicated cases. So only one thing that I would just like to re-emphasize, which is already commented, is that identification of the sac before you proceed with your surgery. Because in cases of trauma, it is very common that you may not find the sac where you are expecting it to be. So if you can do a CT DCG, it is available in your city. Please do that before. See where the sac is. It may be lying somewhere anterior or somewhere superior to where it usually lies. And that is where you should go and where you should approach your surgery. Thank you.
Very nice.
Thank you, sir. So now I call upon the next speaker of the day, Dr. Nandini Botra. Dr. Nandini Botra is a consultant oculoplastic surgeon from LVPI. After completing her PG in Mangalore, she pursued her fellowship in the prestigious LV Prasad Institute, and she specialized in ocular oncology. Her current area of interest is in dacryology and facial trauma. We welcome you, ma'am, to give your presentation on endoscopic DCR.
Thank you, Dr. Pratibha. So I think the pre-operative and the post-operative workup has already been covered by Dr. Vidya and Dr. Preeti. So I'll directly move on to the video presentation. Okay, is my screen visible?
Yes, ma'am. Yes, ma'am.
Yes. So for endoscopic DCR, the first step that we need to do is to decongest the nasal cavity so that all the structures are visible. So let us understand the anatomy first. So on my right, you see the lateral wall of the nose, and on the left is the nasal septum. So as you go in, you see the middle turbinate, and the part where the middle turbinate is attached to the lateral wall is the axilla of the middle turbinate. So your area of the lacrimal sac is anterior to the middle turbinate. So that is the area of interest, or the area of the lacrimal sac. So you go in with a mixture of lignocaine and adrenaline and inject it right in front of the middle turbinate. And then you pack the nasal cavity with gauze soaked with lignocaine and adrenaline so as to decongest the nasal cavity. In some cases of septal deviation, you can choose to infiltrate a little into the nasal septum as well, so that when you remove the nasal packs, the septum will also be decongested, at least the mucosal part. So now we are filling the nasal cavity with the nasal packs. Now after that, we move on to the surgery. So remove the nasal packs and you'll see the view is much more clearer. You see that whitish area right in front of the middle turbinate. That is the area of interest. So the first step is to take a nasal mucosal incision. You start the incision about 10 millimeters above the axilla of the middle turbinate, move 10 millimeters anterior, and inferiorly, you cover about 2/3 the length of the middle turbinate. So that is the length of your incision. And then you just move back towards the middle turbinate. Now, using the periosteal elevator, you reflect the nasal mucosal flap posteriorly. Yes, now you see a bare bone below the nasal mucosa. And this line, what you see, is called the maxillary line. And that is very important because that is, if you look at it externally, it is the area of the maxillolacrimal suture that you see. So beyond that, posterior to that is your lacrimal bone, and anteriorly is the frontal process of the maxilla. That is this bone. Yeah, so now you start with your osteotomy. The first punch is taken at the sac duct junction. So at the most inferior point that you've exposed. And here, this white tissue inside is your lacrimal sac. And how do you confirm it? You press the sac from external and you'll see a movement inside. So that confirms that you're in the correct position. And now you extend your osteotomy. So the osteotomy here will be such that you expose the entire sac from the sac duct junction to the fundus of the lacrimal sac. So I'll tell you how to identify the fundus of the lacrimal sac as we move ahead. So here you can see this is the lacrimal sac, and behind you see the ethmoid mucosa that is whitish in color with a small amount of ethmoid bone over it. So how do you identify the posterior most or the superior most extent of the osteotomy is when you see the agar nasai cell. Agar nasai is the largest ethmoidal air cell. So you would see that, and that is the posterior extent, supero-posterior extent of your osteotomy. And the other way to ensure that you've completed the osteotomy is insert the probe insert the probe through the canaliculus and make sure that the probe is absolutely straight, and then see where it comes on the lacrimal sac. Now here I'm using the suction to separate this thin lacrimal bone which is attached to the sac. This is the ethmoid mucosa and this is the lacrimal sac. So you want to remove this lacrimal bone which is attached to the lacrimal sac, otherwise your posterior flap will not evert completely. So we gently separate it from the ethmoid mucosa so that there is no injury to the ethmoid mucosa. And using the alligator forceps, we just gently bring this lacrimal bone out. It's a very thin bone, so it comes out very easily. There. Now, as you see, this part of the ethmoid bone is right in front of the sac, and we do not want to leave any bare bone in front of the sac. So you gently dissect it from the ethmoid mucosa, and again, using the alligator forceps, you remove that part of the ethmoid bone. Now, even during the external surgery inferiorly, we do remove a part of the ethmoid bone. So that is what we've done here as well. Now we are trying to insert the probe in, and when the probe is directed straight in the palpebral aperture, you can see that it is exiting here. This is not enough. Okay, I'll just take a minute more. This is not enough. We need at least about 5 to 10 millimeters above the exit of the probe to be free of any bone. So we go ahead and drill the bone superiorly. If you don't have a drill, you can still go ahead with a punch. But as we go superior, the bone tends to become thicker and it becomes difficult to punch in that area. So if you have a drill handy, that would be better. So we drill the bone such that at least 5 to 10 millimeters of area above the common canaliculus is free of any bone, and the fundus of the sac is completely exposed. Now that we've exposed the sac completely, we go ahead and take a lacrimal sac flap. So first is to take a vertical. Once we take a vertical mucoid fluid coming out of the sac, then we take back cuts, so that our posterior sac flap falls back on the ethmoid mucosa. That is our posterior sac flap, nicely falling back on the ethmoid mucosa. Suction to remove all the contents within the sac. We can see the probe exiting and there is no bone in front of the sac. Now we evert the anterior sac flap such that it falls back on the bone. So the sac is open like a book. This is 0.02 mitomycin C being applied to the raw edges of the flap as well as the raw edges of the bone. Now that is very important so that we can avoid granuloma formations. Then we do a bicanalicular intubation. Now the last step, which is very important, is to achieve the mucosal anastomosis, as Dr. Lakshmi ma'am mentioned. It is very, very important to not leave any amount of raw bone so that we avoid any amount of granuloma formation. So we push the posterior sac flap back and the nasal flap, which we had created, we push it back such that there is edge-to-edge anastomosis of the flap. And the anterior sac flap, which we had turned anteriorly, actually anastomosis to the anterior mucosa. So that creates a complete mucosal anastomosis. Then using a fibrin glue, we secure the flaps in position. And after that, place the lacrimal stent behind such that it doesn't irritate the littles area, and then do the nasal packing. Now here, nasal packing is very important. Do not stuff it in front of the ostium. Always keep it on the floor of the nose. We do not want to disturb the mucosal anastomosis. So we pack it in the floor of the nose and the anterior part of the nose and not disturb the mucosal anastomosis. So thank you. And if there are any questions, I'll be happy to take that.
Thank you very much, ma'am. I think that was one of the best endoscopic DCR videos I had seen, bloodless, and the clarity was just amazing. Thank you for the wonderful presentation. And just a small question, ma'am. Would you do anything different in a pediatric endoscopic DCR?
So in pediatric endoscopic DCRs, you generally don't need to use bone drills because the bones are so thin that just by using bone punch, we are almost able to complete the osteotomy. So that is one difference. Second is if it's an infant, make sure here we are using a 4 millimeter endoscope. There we'll use a 2.7 millimeter endoscope so that the visualization can improve and there's more space to manipulate inside the nose. Okay. Other than that, never pull any bone in a pediatric case because that might lead to a CSF leak. So whenever we even punch, make sure that the punch is complete, twist the punch and then come out. Never pull the bone. So these are the few pointers that I would keep in mind.
Thank you. Thank you.
I have a question.
Yes, sir.
Yes.
Yes.
Now, very nice presentation, Nandini.
Thank you, sir.
I have a question which goes beyond the endoscopic DCR, and that is that being part of a very well-known bacteriology service with Javed around, and you are taking it to the next level, I would say. How does a patient get an external or an endoscopic DCR? In other words, you are all equipped to do both things. How do you make the decision of subjecting the patient to an external or an endoscopic?
So by and large, every patient, we give them an option. You can select whether you want to get an external or an endoscopic DCR. But I would personally prefer an endoscopic DCR if I had to go through the surgery or if I had to put my parents or my relatives through the surgery, because I feel the destruction is much less as compared to the external DCR. Although external DCR, I do it on a daily basis and it's a wonderful surgery. And there are certain instances where I would actually prefer an external DCR over endoscopic DCR. But by and large, if you say a patient coming to the clinic, the preference would be an endoscopic DCR. If there are no other complications. Yes, in cases of trauma where the bone is so severely damaged, maybe it would be better to go ahead with an external DCR. But the remaining cases, yes, endoscopic is the best way to go, including revision DCRs. Revision DCRs actually do best endoscopically than externally.
So in your patient profile, out of 100 patients undergoing DCR, how many would be external, how many would be endoscopic?
For me, about 90 would be endoscopic and about 10 would be external.
Okay. And for the service as a whole as well? For all the surgeons in the service also, is it 90-10 or does it become 50-50?
No, I think that I talk about me and Dr. Javed per se. The others have their own choice. Yeah.
Oh, okay. Thank you.
Thank you.
90-10 is huge. Nandini.
Yes, sir. Thank
Very
you.
good.
Thank you.
Very nice.
Any other comments from Vikas sir or madam, or we move on to the next?
Sir, any problem while doing revision DCR? What are the problems you come across when you go for endonasal?
Yes, so during endonasal, when you do revision DCR, one is we've not really faced any issue, but yes, once I've had to convert it to an endo cum external approach. But otherwise, it is very simple. When you go in endoscopically, you separate the nasal and the lacrimal sac flaps very clearly. And then whatever is the remnant bone, you drill it off and you get a very nice sac opening. And that is when you create a mucosal anastomosis and it's complete. It in fact takes about 15 to 20 minutes even to do a revision DCR. Doesn't take more time. Yeah. In fact, when you go externally, you encounter so much of fibrosis in revision DCR that personally, I would prefer doing an endoscopic DCR because the fibrosis is much less.
How about bilateral DCR?
For endoscopic, yes. Prior to the COVID era, we were doing bilateral endoscopic DCR because post-operative recovery is very good in endoscopic DCR. That is, patient does not really complain of pain. But right now, due to COVID, we are not preferring to go ahead with bilateral. But otherwise, yes, bilateral is preferable.
How about in acute cases, madam? How comfortable you are?
Yeah, so we can take them up immediately. So if I see a patient today in the OPD with lacrimal abscess, I would take them up as early as tomorrow. I would start them on antibiotics today, and tomorrow is when I would go ahead with an endoscopic DCR. Two advantages. One, the patient does not have to go through that pain of healing and the pain that is persisting because of the lacrimal abscess. And second, it's an immediate relief for the patient. Next day, when you see the patient is very happy. The pain is all gone and the patient is very comfortable. So yes, immediate DCR would be preferable in those cases.
And one quick question, do you use GA for all your endo or you also do it under local?
Pardon, sorry?
Do you use GA for all your cases or you also do endo with local anesthesia?
Okay, so for externals, I do it under local anesthesia, whereas for endo, I prefer only general anesthesia because there's a lot of posterior collection of fluid when you're actually doing endoscopic DCR, and I feel the patient won't be comfortable. So I prefer to do it under general.
I do a lot of my endo with local and sedation. It depends on the patient selection, I feel. Sometimes preoperatively, the patient is comfortable. You can do under local.
True, I agree. I know a lot of people who do it under local. I think it's just a personal preference that I would do it under general anesthesia.
Even here, we do it under, in RIO, we do it under local only.
Yes.
Only pediatric age group, we go for G.
Okay. Thank you. Thank you for the wonderful inputs. For want of time, we'll move on to the next talk by Dr. Ruchi Goyal, ma'am. So Dr. Ruchi Goyal is a very dynamic oculoplastic surgeon who is currently in Maulana Azad Medical College. She has held multiple positions in AOS and she is the editor-in-chief for DJO. She has had more than 90 publications and has written chapters in many textbooks and has many academic and community awards. We welcome you, ma'am, to the TNOA Connect series and looking forward for your talk. Thank you.
Thanks, Dr. Pratibha. And for not only, giving me this opportunity, but also remind me how I looked 15 years back. And I was the editor long time back. So, okay, I've started sharing my screen. Can you see my screen now?
Yes.
Yes, sir. Okay. So I've been given the talk on how to do a conjunctival DCR. Just a quick recap of what really we mean by canalicular obstruction. So up to the first 3 millimeter from the punctum, we call it as proximal obstructions. Then up to 4 to 6, it's the mid-level, and beyond 6, it's the distal obstructions. So now the various modalities that are available are canalicular trephination with intubation, the retrograde intubation with the DCR, and the conjunctival DCR for this purpose. Now, this is the technique which I use for doing a conjunctival DCR, and this was published in IDEO. So let's go to the video now directly. Now, the incision is somewhat similar to what you do in this is the external conjunctival DCR which I'm showing, and this is the flap, mucosal flaps which are being created. And The only difference is that the osteotomy size, we don't need to go for very large osteotomy. A 6 to 8 millimeter osteotomy is sufficient. And this is how you partially excise the caruncle, and using a bone graphies or even an MVR knife, you create a track and just watch. This is how you fix the tube. This is a straight glass tube without any eyelets. So this is a 6-0 proline, which is first tied all around the cuff, because if you miss this suture, this tube tends to retract into the nasal cavity. So this suture is extremely important. And then, like a mirror is stuck on a any cloth, this is the same kind of technique. You create a cross mesh around the opening, and this is a little tedious. You have to be very patient. These sutures may tend to slip again and again, so you have to be very slow and meticulous in doing this, because here the tissues are not as stretched as when you're working on a piece of cloth. So after you create a mesh, what you do is you identify the center and then you move outwards, like you put in a button hole in your cloth. So it's a similar kind of a maneuver. You are going from the center towards outwards, and you tend to create a kind of a net all around the tube. Now you identify that your tube is correctly placed, and this is the mucosa being sutured. And of course, after that, on the table itself, you must confirm that your tube, if your tube is correctly placed, you can see on the table itself the drainage starts. So these are the some post-operative pictures, and this is the image below shows a 1-year-old follow-up. And surprisingly, some of these patients, even the proline gets covered by the mucosa, but in other patients you have to remove the proline suture. I'll just share another technique which we recently have started doing, and we have published it in Canadian Journal. And here we again, retrograde intubation with the pseudopunctum creation has been described by previous authors. And this is the same probe which we usually use, and it's bent at about 80 degrees. And this is the technique that is being done. So all the patients where we have a block less than 5 millimeter, I first try and attempt this procedure instead of going for conjunctival DCR directly. And unlike what ma'am has advised us, I'll try to do it with the posterior flap intact, but it sometimes becomes difficult to actually do a retrograde cannulation if you have to do it, because you need a very wide exposure to pass the lacrimal probe back. So we try and identify the exit of the probe somewhere towards the conjunctival sac and side, and we make a small lick, and this pseudopunctum is created. And through this pseudopunctum, suppose we intubate using the routine silicone intubation which we have in our OTs. And only difficulty is that you have to be very careful to identify where you are exiting and not damage the canalicular lining. So it must be done under high mag. And after that, of course, the intubation and everything is same. And I usually keep these tubes, the silicone tubes, not more than 4 weeks now, because Dr. Javed Ali has been continuously emphasizing, and I'm a great follower of him. So these are the pseudopunctum which are sutured as well at the margin. And this is the post-op 12 months image. This is the on the right side. You can see the anterior segment OCT picture, and you can see the pseudopunctum over there. This is the actual punctum, and this is the pseudopunctum which we created. So we found that patients where you have the remaining canaliculus intact, instead of directly going to conjunctival DCR, you can go for this approach, and you tend to avoid the complications and problems which are associated with the bypass tube. And only thing is that while trying to dissect, if you encounter that, because once you're seeing preoperatively, you cannot ascertain what is the extent of the block, how long the block is. So wherever you are encountering difficulty in intubation retrogradely, in those cases, it is better to directly go for conjunctival DCR. So nowadays I keep both the things standby whenever I'm doing working on these patients. And of course, the initial intervention, as is the dictum, is that you should try trephination with intubation. These work well in patients with stenosis, but when you have post-traumatic or extensive obstructions, then you have to go for a more definitive procedure. Thanks so much.
Thank you very much, ma'am, for the nice presentation. Over to panelist Ravindra Mohan, sir, your comments and experiences about this.
Very nice presentation, Dr. Ruchi. This is obviously a very difficult area, particularly the fact that anatomical success is one thing and functional success, where the patient's normal eye closure, normal activities, all that is goes on unhindered with a normally functioning lacrimal system. So I just want to ask Dr. Ruchi, anatomical success, one can actually make a pseudopunctum anywhere or do, but we oculoplastic surgeons have often been blamed even in editorials and OPRS for thinking mechanically. So from thinking mechanically, does it become a good functional success in these patients when you ask them how they're doing in terms of watering? So I just want to get a feel of these surgeries, some of which obviously I'm not very familiar with. So does the mechanical success, anatomical success convert into a functional success?
Sir, not in all cases. I totally agree with you. But then most of these patients are those cases when you have tried everything and nothing is working. So yes, nowadays a lot of people are shifting to Botox injections into the lacrimal gland to do away with these extensive procedures. But then again, people have reported that after giving 2 or 3 injections, actually the watering goes down to such an extent that you don't really require these procedures. But then, giving the kind of setup we are working, we do have Botox, but then we try to limit the use to Botox to something like blepharospasm and not, inject these Botox indiscriminately for watering. So yes, I agree with you. Sometimes we have patent tracks, but the patient is still, complaining of, if you go for monk scoring, cleaning the eye at least 3 to 4 times is always there. And we have to talk to these patients. But as I said, yes, until the patient is quite motivated, I never go for conjunctival DCR. Conjunctival DCR is it's like, along with the patient, it's your lifetime follow-up also required. So something keeps happening, but lots of patients do well once the tube is well positioned and it's kind of accepted by the body, let's put it that way, and the patients learn to take care of it. Patients do well and they don't complain of watering. So it's, but I can never really predict which patient would be 100%. So I never promise anything to my patients. So if they do well, it's fine. If they don't do well, it's their risk always.
So do you have any experience with partial dacryoadenectomy or removing a part of the lacrimal gland, which also destroys some of their openings?
I am a little more conservative. It's, I agree with you. Yeah, it should theoretically work and must be working in the hands of a lot of people. But no, if I really want to go for some procedure like this, I would rather inject Botox rather than doing that. Yeah.
Thank you.
And which tube do you prefer, ma'am? Which company and what tube?
This is let's not put it standard company. This tube is locally prepared in Agra. And I came across it because Gangaram people were using it. It is prepared by somebody called Agarwal. Now he's, after, we did a lot of thesis with it. So he has got so much of, he's kind of patented it. It's available in Delhi. I don't know where all it is available. In Delhi, it is available and it is a straight glass tube. And this guy is possibly a bangle maker who turned into a Jones tube maker now, or what, let's say lacrimal glide. But he does it, makes it well, and it functions well because lots of thesis and a lot of research has been done using that tube. Actually, it would be a much better idea. Of course, we don't have stop-loss tube, and the kind of patients we have, they are not able to afford, especially this kind of patients, they cannot afford expensive stuff. So this tube is about 600 rupees and it's quite sturdy. I wish somebody would come up with a cheaper, kind of a tube with holes that would ease out all these procedures to a large extent. But at least in our part of India, like where we are staying, we still don't have ones with eyelids. So we are using these.
Thank you.
Ma'am, hi ma'am. Hello.
Sorry, sir.
Hello.
Carry.
So you mentioned that the proline sutures that you put, you remove them ultimately after
No,
some time?
the picture I showed, in fact, most of these were study research patients, and as a dictum, the students, they follow them up and they show me after a long time. And actually lots of these patients, I have not even touched the proline. I have not touched anything, nothing. The mucosa grew over it, but yes, not in all patients, not in all patients. Some patients, the tube remains there once it gets, kind of, it finds its way. I removed the proline which is extruding, and I have had patients where the conjunctival overgrowth has been there, and I had to excise those, put MMC, and there are patients where even I had to remove the tube. So again, as I said, I cannot predict what is going to happen. And some patients, they just do well, and some patients, despite all the effort, they don't do well.
Because many times we come across granuloma formation around the proline knot where we fix this tube.
So yeah, I have had encountered granuloma formation also. So if it is not sitting on the mouth of the tube, I simply excise it. If the conjunctiva is kind of grown over it, I just put MMC and give a little bit of steroid drops for a couple of days, and they do well. But there have been instances of recurrent granuloma, and possibly proline suture per se is not a very friendly suture, let's put it that way, in the sense that if you leave it there, it tends to excite some kind of a reaction in some patients. But otherwise, once the tube is in position and it's snugly fitting, you can remove these sutures, yes.
And ma'am, what about the pseudopunctum that you create in retrograde intubation? What is the reclosure rate in your cases for that?
Again, the study which we published, in that it was because these follow-ups are just limited when you are doing these research activities. So, and in 1 year, lots of these patients, because were doing well, except for 1 or 2 patients where they did close. But then you have two pseudopuncta. If one doesn't work, the other one works. So, but yes, again, I would say that this is not still, if you say something like external DCR, yes, it's going to work. But these all procedures, you cannot never be 100% sure what is going to work. So I've had situations where I had to go back and check what's wrong with my pseudopuncta and dilate them after 1 year had elapsed. So yes, problems are there.
Because I tried this technique in a very few cases long time back, but then all the pseudopuncta would get closed ultimately. So
there is another thing which I've started doing, because of late, like instead of going retrogradely, what I've started doing is that I directly cut on the canaliculus, the conjunctival side. And I guess by putting the probe retrogradely, you tend to cause a little more injury to the lining of the canaliculus. So if you go the other way around, like we intubate, you just whatever side you're feeling the obstructions about, so it's a 2 millimeter, you give a small cut a little distal to it, and then under microscope try to see if you can identify the canalicular opening, and then you pass your probe. So that tends to injure the lining less than what you do it when you pass it retrogradely. But again, as I said, you can give it a first try, talk to the patient, because the next best option is conjunctival DCR. So, this is at least less invasive than that one.
Ma'am, if you are able to find some amount of a normal intact canaliculus from the conjunctival side before you go in for DCR, then why not just put a mini Monoca stent there and not do the DCR at all?
I've started doing that. Patients, again, mini Monoca each is going to cost a lot. So, there are a lot of financial constraints. Again, we need some Indian companies chipping in and making
stent is there, ma'am. No financial disclosure, but that's much cheaper than the Western imported ones. So
I guess we need to get that, because right now we are using only the imported mini Monocas in our patients. So I'll get the Oro stuff.
I've been using that one since I've come here. Earlier I was also using that, but now I find that the results are equally good.
I think down south, they please share a lot of your plastic things with us in Delhi.
Thank you, ma'am. You made that simpler. And as you rightly said, these surgeries have a lot of complications, so patient preference is very important. So lacrimal gland Botox also plays a very important role. And you said that after 2-3 injections, the gland shrinks and the watering actually kind of reduces. So a lot of learning points. Thank you, ma'am. And so now we move on to for want of time, we'll move on to the next speaker, Dr. Mohammed Shahid Alam, who is here today to give his talk on lacrimal tumors. We have to be very careful about lacrimal sac tumors also when we deal with DCRs. So here, Dr. Shahid Alam has completed his master's in Aligarh University, and then he did his fellowship in Shankar Nethralaya. He is currently heading the department in Kolkata Shankar Nethralaya, and his areas of interest are orbital and neck cell oncology. And having worked as a colleague with him, I know his passion and involvement in oculoplasty. So we welcome you, Shahid, to give your presentation.
Yeah, thanks, Pratibha, for the nice introduction. Am I audible?
Yes, Shahid.
Yeah, there's a little problem with my voice with my laptop, so my voice might be a little feeble. So, is my screen visible now?
No. Yeah.
Yeah, so I'll just go ahead with my presentation on lacrimal sac neoplasm. So just to brief the outline, I'll first brief about some few cases that we have managed on lacrimal sac neoplasm, and then a small, very brief literature, and then our experiences with lacrimal sac neoplasm. It's such a rare condition that, sorry, I don't have any video of of managing such cases. I've informed Pratibha also regarding this. So I'll just go ahead with the presentation.
You can go ahead, Shai.
Yeah, actually, the slide appears stuck. Just 1 second.
Yeah.
So yeah, it's a 56-year-old female who had actually presented to us with complaints of swelling in the left lacrimal sac area, which had been there for like the past few months. She had already undergone a DCR elsewhere, and it had actually failed. And she presented with all signs and symptoms of acute dacryocystitis. And when we examined, we could actually feel a mass in the sac area, which was going above the MCT, and that raised a doubt regarding any mass in the sac area. And then we ordered an imaging, and this is the imaging picture, the CT scan, both the axial and coronal cuts. As you can see here, this is an ill-defined mass filling the lacrimal sac and NLD, and there is erosion of the lacrimal bone. So the provisional diagnosis was a lacrimal sac neoplasm. So an excisional biopsy and the frozen section control was done along with an ENT backup, and the mass was sent for histopathology. And this is the histopathological picture, which showed tumor cells, malignant tumor cells, which had both an epidermoid component and a glandular component. It was a case of mucoepidermoid carcinoma of the lacrimal sac. So a patient received radio post-operative adjuvant radiotherapy, and then he had 3 recurrences over a period of 5 years, and she had to undergo exenteration. And last time we talked with her, she was from Bengal, and this was a case when I was doing my fellowship in Chennai. So last time when we talked to her, she was alive, and at that time she had a follow-up of 7 years. Now this is another case, a 48-year-old male presenting with complaints of watering and bloody discharge on the left eye for the past 3 years. Previous diagnosis was again chronic dacryocystitis, and he had a past history of endocanalicular laser DCR done once, endonasal DCR once, twice external DCR, and 6 times he had undergone incision and drainage for suspected lacrimal sac abscess. And this is the imaging picture of the patient, which shows an ill-defined soft tissue mass in the medial canthal area, which is actually infiltrating the nasal cavity, ethmoid sinus, and here you can see there's erosion of bone, and this is the DCR ostium, suggesting the previous DCR. And nasal endoscopy was done, which showed fleshy mass filling the left nasal cavity, and a biopsy was taken at the same time. and endoscopic biopsy showed papillary squamous cell carcinoma of the sac and sinonasal cavity. So finally, a combined approach, including a team of otolaryngologists and us, was done, and patient underwent a transnasal endoscopic medial maxillectomy and anterior ethmoidectomy and complete removal of the lacrimal sac mass through nasolacrimal duct and through external approach. That is combining both ENT and oculoplastic therapy, and he was doing well at the last follow-up of around 4 years without any recurrences or metastasis. This is a third case. That patient presented with proptosis, right eye proptosis, which had been there for the past 6 months. And here, on the MRI, you can see more or less a well-defined mass in the inferomedial orbit, which is adjacent to the sac and going to the NLD. Patient was advised incisional biopsy when he presented to me, but then he got a biopsy done elsewhere, and he came to me with a biopsy report which showed a gland adenocarcinoma. So we got the slides and blocks reviewed with our pathologist, and it again suggested that it's an adenocarcinoma and possibly arising from lacrimal gland and metastasis, or could be a metastasis, because at that time we didn't have any a clear clue that it's arising from the lacrimal sac area, because patient didn't have any obvious medial canthal mass. Patient just presented with proptosis. So we did a PET scan to rule out any metastasis, but there was just metabolically active lesion only in the medial orbit, and there were no systemic hotspots. So considering the diagnosis of an orbital adenocarcinoma, so we had to do a lid sparing exentration. And here you can see this area which was where bone involvement was there. The patient also had to undergo partial maxillectomy. And this is the histopathological picture, which came as a surprise to us. So there were neoplastic cells arranged in focal cribriform pattern, duct-like structures infiltrating a desmoplastic stroma. There was high mitotic activity, and there was areas of decapitation secretion. This is the area of decapitation secretion, which is quite typical of an apocrine adenocarcinoma, and the mass was arising from the lacrimal sac, so which was confirmed on histopathology after exentration. So it was a case of apocrine adenocarcinoma, and it was the first case of apocrine adenocarcinoma reported in literature, which we published few years back. So just to give a brief outline of lacrimal sac neoplasm, it's an extremely rare condition, and there were approximately 725 cases reported till 2017. There's a disparity in histopathology in the lacrimal outflow system, whereas the canaliculus is lined by the stratified squamous epithelium. There is a stratified columnar epithelium in the sac. Then the NLD is lined by the ciliary respiratory epithelium. So diverse tumors can arise from the whole lacrimal drainage apparatus. Management is extremely challenging owing to its anatomical position in the medial canthal area, where achieving a complete R0 is very difficult. And then you have to sole oculoplastic surgeon cannot manage this case, and you have to take help from your ENT colleague. And then it's notorious for recurrences and metastasis. Just a brief classification, it can be classified into primary and secondary. Primary can be epithelial, non-epithelial, and secondary can be sinonasal or from the surrounding adnexa. Epithelial tumors, the most common ones are squamous cell carcinoma, transitional cell carcinoma, and mucoepidermoid carcinoma. And then there are adenoid cystic and adenocarcinoma. Non-epithelial, the most common one is lymphoma. There can be melanomas and sarcoma. Of course, there is a debate about how a melanoma or adenocarcinoma can arise in lacrimal sac, since there is no melanocytes or any glands, but then that's a thing for another day. So presentation, the most common presentation is watering and a medial canthal mass. Their presentation, as you've seen here, proptosis, epistaxis, rhinorrhea, or numbness in the sac area. Hemolacria, which was previously thought as an important feature of sac neoplasm, is actually quite rare, and in some of the literature, it has been attributable to melanoma. It mimics chronic dacryocystitis. So most of these patients, they will present with chronic dacryocystitis, and then more so in cases of lymphoma. So when you do an imaging, and the choice of imaging is doing both a CT scan and an MRI combined along with a CT DCG. So an obvious mass will be seen. There can be surrounding bony dissection, and this is the DCG where you can see the right NLD is filled with the dye, but here you can see a mass without any dye along the left nasolacrimal duct. So the management is, of course, an incisional biopsy, and if you find a mass during doing a DCR, So at that time, it is advisable to convert a DCR into DCT and don't make any ostium. And if it is a localized lacrimal sac mass without any evidence of sinonasal orbital invasion, there should be you should do a DCT with complete removal of NLD and surrounding periosteum with a rim of healthy tissue. And this is a classical incision that that is given for complete removal of the NLD. In cases where there are bony erosion or involvement of ethmoid or maxillary sinus, you have to do partial or complete ethmoidectomy or maxillectomy, and all of these cases will receive adjuvant radiotherapy. So we published this paper recently. It's the first paper from India on lacrimal sac neoplasm. We had 14 cases over the past 24 years. So you can see how rare the tumor is. The male-female, this thing, well, both sections are like equally involved. The most common symptom was a mass in the medial canthal area, followed by epiphora. 7 cases were misdiagnosed as NLDO, and 6 had already undergone DCR before presenting to us. We had 13 epithelial and 1 non-epithelial tumor, which was a small B-cell lymphoma. So 7 cases underwent wide local excision, 3 underwent DCT, and 3 had to undergo exentration. 6 cases received radiotherapy. Finally, 4 cases had local recurrences and regional mets in 3, out of which 2 had lymph node metastasis, and in 1 case there was mets to the angle of the jaw. So the mean duration of follow-up in our cohort of patients was 40.7 plus minus 25 months, and 4 cases actually had 5 years of follow-up. So this is a study that which we published recently on lacrimal sac neoplasm. So that was like quite brief about sac neoplasm, and just to conclude, it's an extremely rare neoplasm, and mass extending above the medial canthal tendon and epiphora is the most common feature. And whenever you see a mass, whether how to confirm, how to like make sure whether it's a lacrimal sac mucocele or it's a lacrimal sac mass, just see whether it's eroding the medial canthal tendon or not, or it's going beyond above it or not. Epithelial tumors are far more common, and multidisciplinary approach involving wide local excision and adjuvant radiotherapy is the management of choice till date. Systemic workup along with chemo radio for lymphomas, and yeah, it's notorious for local regional recurrences and distant mets. So like regular follow-up is mandatory. Thank you.
Wonderful, Shai. That was a huge collection of cases which you have seen and nicely presented. And you also correctly highlighted the importance of the red signs, which we have to look in when we see a mass in the medial canthal. If the mass is slightly above the medial canthal area, or if it is firm, and if we see some suspicion in the nasal endoscopy, then we should do an imaging definitely. Or if there is epistasis or tears, red tears, then we should definitely do an imaging before undergoing any surgical procedure. Dr. Ravindra Mohan sir, your comments.
Yeah, nice series of cases. I remember 1 or 2 cases that we must have seen during our time there as well.
Actually,
now there are 2 parts to the question. You did very nicely highlight the fact that any mass, because on one side, mucoceles and lacrimal blocks are extremely common, and on the other hand, lacrimal sac tumors are extremely rare. So obviously, any kind of screening doesn't work. For example, there were also at some time efforts to send every posterior sac flap or a biopsy from every sac flap, which basically doesn't work out in terms of finance or loading the pathology department with too many tissue, which is going to show only inflammation. So preoperatively, you mentioned that hard mass, for example, or something where there's blood stained tears, or the mass is clearly extending above the MPL, would very strongly lead to a suspicion of lacrimal sac tumor. But at times one may also open up the sac and find that there's something abnormal. Have you come across any such abnormally thickened sacs? And what do you suggest?
Yeah, sir, that's an important thing, sir, that you have raised. Actually, yesterday OT only I had such case where when I opened up the sac, so there was a granulation tissue inside the sac. So I didn't have a doubt about a tumor. I thought like there can be rhinosporidiosis, or in long-standing cases of mucoceles where there are a lot of inspissated pus inside. So it also leads to forms granulomas inside. So I did the routine DCR, and all those tissue which was there inside, I sent it for histopathological examination. But then, yeah, if what I suggest, like a lot of us are in a habit of raising the nasal flap first. I don't know, that's what I do. But then I think it's a good idea to make the sac flap first. And if you see a mass inside, and if you have a strong suspicion that no, it can be a neoplasm, like by looking or having a feel of it, you can make out that it's a granulation tissue or it's a mass. Then at that time, I think a bony osteotomy should be avoided. Just remove the whole area, send it for histopathological examination, and then maybe depending upon the histopathological diagnosis, we can proceed ahead. So that's what I feel, that a sac flap should be created first, and later on a nasal mucosal flap.
Okay, thank you.
Shahid, excellent presentation and very good collection of cases. As you rightly pointed out, see that it's very, very common to have recurrences and some of these patients landing up with exenteration subsequently. So first thing is that it's very difficult, as Dr. Ravindramohan sir also pointed out, that it's very difficult to screen out these patients many times before you actually put your knife over the area to see whether there's a tumor there. So you can't subject every patient to a CT scan before DCR surgery or anything like that. Secondly, what happens is that it's during surgery also, even if you identify the mass or something and you try to excise it completely, it's usually very difficult to get clear margins in such a case where it's a malignancy especially. And what happens is, if you don't treat these patients subsequently with an adjuvant radiotherapy or a chemotherapy, whatever is required depending on the pathology, then ultimately these patients are likely to come with recurrence as with any other malignancy anywhere else in the body. So it's very important to completely clear. If you know that, if you have a suspicion, always do a biopsy first, identify the malignancy, and then go for a medial maxillectomy in combination with an ENT surgeon or a head and neck surgeon, and completely clear off that area and follow it up with the proper chemotherapy and radiotherapy wherever it is indicated.
Yeah, correctly pointed out, Dr. Vikas. Yeah.
Okay. Thank you, sir.
Very nice.
Any comments?
No, I just have one point, or rather 2-3 points. One is there will be a little bit of a telecanthus, and invariably when there's a mass in the sac, which is so rare, the syringing will be patent. Generally, it won't be a complete block. Of course, a bloody discharge, as already Shahid has said. Please remember, lacrimal sac has transitional cell, just like your urinary bladder, and carcinoma is devastating. I don't know whether that patient which I had seen, I forget his name, Ram Prasad Rao, is in this list because he died 6 months after the diagnosis. So these are transitional cell carcinomas and they are extremely lethal. Thank you.
As you told, there is another case which I came across, ma'am, which underwent repeated debulking and radiotherapy. Still, they are coming to us with the same problem. UNT people have already done maxillectomy for them, and even it is spreading further. They are really aggressive ones. Initial state, as you said, the syringing was totally patent through.
You have to do the neoadjuvant treatment, which Shahid has pointed out. They need that multimodal treatment. It's very difficult to clear out. See, even in a DCT, it is so difficult to take out every part of the sac. Where are we going to take out every part? And invariably, you will be damaging. You can even damage the cribriform plate because the bone is thinned out. So please go for neoadjuvant treatment for these cases. Multimodal treatment.
Agree with the points, and thank you for the valuable inputs, ma'am and sir. So with this, I think we end the session on lid, all we have to know about DCR. And now we move on to the session on lid. So I welcome the panelists. So here we have Dr. Usha Kim, ma'am. So Dr. Usha Kim is one of the role model and mentor for many of the young oculoplastic surgeons, including me. In fact, I took oculoplasty after getting inspired by her. She heads the department of orbit oculoplasty department in Aravind Madurai, and she has been specialized. She has done specialized training in California, and she runs the Ray of Hope, in which they do a lot of free surgeries for unaffordable people. And she has done many publications and presentations, and she has trained many PGs and fellows. We welcome you, ma'am. And then we have Dr. Lakshmi Mahesh, ma'am, who needs no introduction. She was the former director of Orbit Oculoplasty Department in Shankar Nethralaya. And currently she is the oculoplasty consultant in Manipal Hospital, Bangalore, and Netradama Hospital in Bangalore. She has trained many PGs and fellows, and she has many publications and written textbook chapters. And she is one of the active members of AOIs and OPAI. We welcome you, ma'am. And then we have
Pratibha, please correct. It's 3 years since I quit Manipal. I'm no longer with Manipal. I'm at Sakra World Hospital and at Netradama.
Okay, sir. Okay, ma'am. Sorry, ma'am. And then we have Dr. Aparna Bhatnagar, who is the ex-fellow of Shankar Nethralaya and has done her fellowship in UCLA. And she's currently the consultant in Vanagaram Apollo. And she has won several awards and publications. And personally, I know that she's an excellent artist and an excellent human being to work along. So we welcome you, ma'am. And I invite the first speaker of this session, Dr. Sendil Nathan. Sir has finished his fellowship in SN and has done his fellowship in Leicester Royal Infirmary, UK, and currently the director of Ramana Eye Hospital and is the visiting consultant in Rajan Eye Care. So he's an excellent oculoplastic surgeon. We welcome you to give your talk on ptosis correction, sir.
Thank you, Dr. Pratibha. Shall I share my screen now?
Yes, sir.
Yeah, I also would like to thank Dr. Pratibha and the TNOA for giving me an opportunity to speak here today. And today I'm going to speak to you about the levator surgery. And we know the ideal patients for LPS surgery are patients who've got mild to moderate ptosis with fat to excellent levator action. And usually the aponeurotic ptosis are the best patients to do because they only have aponeurotic dehiscence. So you can see for this, for example, in this patient who's got the classical highly placelet crease, significant ptosis with good levator action, and very careful because, for example, the eyes test, you can see the ptosis completely disappears. So very fast. Always do a proper evaluation before you start surgery. So the basic surgical principles are: you identify, disinsert, and reattach the levator aponeurosis or tarsal plate at an appropriate height, reform the lid crease, and then match it with the other eye and avoid overcorrection. So with this, I'll just play a pre-recorded which will detail the steps of the levator surgery.
Sendil is in a voiceover, but we can't hear the voice.
Okay. Madam, do is you can see the dehisced levator aponeurosis, and you can see the cornea actually shining through the dehisced aponeurosis, and that above the tarsal plate you should have the attachment of the levator aponeurosis is dehisced. You can see only the conjunctiva and the little bit of mullus is there. You can see the cornea shining through. That's a little bit of mullus there, and now the septum is still intact. And what we will do in the next step is we'll open up the septum and completely so this is a example of a levator aponeurotic dehiscence. The attachment of the levator aponeurosis to the tarsal plate, it should be like that. It should be attached to detached. So the next step, what we do is we open up the septum. You can see now the septum is intact. The fat is actually still held back by the septum. There's no fat now. And once you open up the septum, the fat will prolapse out. And once it prolapses out, you have to identify the levator aponeurosis, and reattach it to the tarsal plate. So now we are opening up the septum. And once you open up the septum, you'll see the fat freely flowing out. And that is a sure indication you opened up the septum. You can see the fat has now come out completely. And what lies underneath the fat is the levator. So you can see we've got hold of the levator aponeurosis, and that's the detached edge which I'm holding. And underneath that, you can see the cornea, which is just covered by the convolvulus. That's the levator edge which I'm holding, and this needs to go back to the tarsal plate. It has to be reattached to the tarsal plate. So if it is not a aponeurotic dehiscence case, the Whitnell's ligament, you can see on top, the whitish line which you can see just beneath the Demar retractor, which I'm demonstrating, that is the Whitnell's ligament. So that is the highest point of the levator aponeurosis. So you can almost go up to the Whitnell's ligament when you're doing a levator resection. So if it is going to be a pediatric ptosis, if there's no levator dehiscence, what you'll need to do is you'll have to do an additional step where you insert the levator attachment to the tarsal plate. So here we're taking the tarsal bite, partial thickness tarsal bite. You just invert the lid, full thickness, because if you've gone full thickness, the suture edge will irritate the cornea, and the patient can have corneal problems following surgery. And so I usually use a Weichel double-armed Weichel suture. And once you've taken a bite from the tarsal plate, pass it through the detached levator and just place a stay suture and examine the lift. So you ask the patient to sit up and see the lift. You see the contour. You see if you've got the arch of the lid right. And if required, you have to again loosen up the suture and reattach it at a different position. And you can see it's a little bit overcorrected now. So what you can do is you can do all the adjustment intra-op itself. So once you're happy, you place 2 more sutures, and you can see you're taking 3 bites. The aponeurosis is now completely reattached to the tarsal plate. You can see the healthy, thick aponeurosis attached. So this is going to be the final end point. And when you close up, what you need to do is you need to take what is called as a crease forming suture. That is, you take a skin orbicularis, and then you take a bite from the levator aponeurosis procedure. You'll have to do it in the other eye also. So this is a bilateral case. So you do the same procedure, and this is how the patient looks at the end of the surgery. And usually you can get very good results if the patient has got a good levator function. And these are some of the ideal patients which the levator action is very poor. Some complications are overcorrection, undercorrection. You can have lid contour problems and corneal exposure. So again, since the levator action is very good, you have to be very careful that you don't overcorrect these patients. So the 0.5 to 1 millimeter below the upper limbus, so that following surgery, the lid will go up a little bit. So if the levator action is not that good, then you can leave it right at the limbus itself. If the patient has got overcorrection, you can manage it easily. You can give downward traction. You can do early suture release, and they usually do well. And these are lid contour abnormalities. You have to be very careful where you place the central bite. It has to be right at the apex of the lid so that you get a pleasing lid contour. So in conclusion, levator surgery gives examination, and the meticulous surgical technique will ensure a good outcome. Thank you very much.
Thank you for the wonderful presentation, sir. Usha ma'am, your suggestions and comments on levator resection.
Very nice presentation. I think there was few glitches with the internet connectivity. That apart, I think the surgery went on very well, Sendil. And I think the anatomical landmarks you highlighted very well. What we need to understand is the reattachment may not always require complete resection, as the algorithm often talks about. So sometimes you just have to go and attach it. All that you need to do is just reattach it. At probably mid tarsus would be the point I would aim at. And I think that's very important, and always comparing it with the other eye and having a good local anesthesia and anticipating a drop in a kind of poor levator action, that's somewhere in the fair category, where your levator action is less than 8 millimeters, probably you will kind of overcorrect on the table. And when you have a good levator action, you would kind of undercorrect on the table. That apart, I think all the steps have been very, very well highlighted. Thank you, Senthil. That was very good.
Thank you, madam. Thank you.
Dr. Lakshmi.
Very nice, Senthil. You have really highlighted, as Usha said. Now you have shown a couple of overcorrections where you do a conservative treatment first. So how long would you wait for the conservative treatment before you go in and release the cardinal suture?
Yeah, if the overcorrection is gross, significant overcorrection, you can straight away go and just cut one suture in the middle, and the lid will drop. If it's a mild overcorrection, then you can.
No, I agree with you. That is point taken. But when would you want to do it? How long? Because sometimes the patient gets impatient. They will not want to wait.
Yeah, maybe you can do it in 2 or 3 days time. I just try to put the
3
patient
days
on.
only you will give conservative the pull?
Yeah, 2 days. Yeah, just try. In fact, if they have significant overcorrection, like the patient which I showed, you can go straight ahead and just open up the central suture. You just open up the skin suture and just cut the central tarsal bite only. Don't cut the ones on the edges. You just cut the central tarsal bite which is holding on to the levator aponeurosis, and you close up. You don't need to pull the suture out.
I was asking you mainly about the timing.
Timing is, if it's significant overcorrection, do it the next day.
Or you would like to wait for a week or two?
If it's mild, you can wait. But if it's very gross, you can straight away do it the next day.
Okay. The thing is, for the benefit of the postgraduates, what we would suggest is maybe the point for aponeurotic is undercorrect, right? If the levator function is good, you would want to undercorrect.
Very good levator function. Don't leave the lid on the limbus. Sometimes it will go up immediately. Leave it slightly below.
And in congenital, you leave it 2 millimeters above the limbus. Excellent.
You are muted, ma'am. You are muted.
One point that Dr. Senthil mentioned, leave the medial and the lateral sutures intact, and you just have to cut the central suture. That's a point that we need to remember. In very grossly overcorrected.
If it is undercorrected, when would you advise, ma'am, to take up for surgery?
It depends on how is it the edema that's causing the undercorrection? You may again have to wait for a week. Healing. But if it's a gross undercorrection, again, patients will not be very patient with you. You can go up and do the correction. But when it is a mild undercorrection, you can wait for a week and see.
Okay.
Can I make some points?
Yes, ma'am. Yes, ma'am.
Yeah. So, Dr. Senthil, very good presentation. Just few pointers. Like for overcorrection, you said you can immediately go in for correction the very next day, depending on the overcorrection. Maybe we can try doing a little massage, what I usually do sometimes when it is a mild to moderate overcorrection, rather than giving an exposure again the very next day. Like a little massage and a downward traction pulling of the lid might sometimes help such patients, and we can, dismiss the patient into going into theater the very next day. So that is what I do. And talking about the horns, the lateral and medial horns, how often do you kind of sacrifice the horns during your surgery versus preserving them?
Yeah, usually the horns, I usually never cut them. I don't cut the horns at all. So I just keep the horns intact.
Sure. And the third point was, when you were exposing the conjunctiva, when you were separating the aponeurosis and all, we could see a sheen of conjunctiva. Do you also remove or dissect the molars? Because probably if we are going for a aponeurotic reinsertion, we might not go in for a molar intervention also. So I thought the conjunctiva was a little more thin than is expected. So
the molars, usually I don't try to dissect it separately, because here the pathology basically is a aponeurotic dehiscence, and the levator action is very good. So all you need to do is put only the levator aponeurosis back to the tarsal plate. And like you saw, you just check once you have made the central bite and see how the lid goes up. the lid goes up extremely well, then you don't really need to, because the molars is very vascular. Once you try to dissect it, start bleeding, and that is when you will actually have problems. Then the field will become bloody, and then you'll have post-op edema, and because of the edema, actually the suture can give way also. So molars, when you will actually try to include it in the dissection, is when actually the patient has got a significant ptosis with poor levator function. Suppose it's a congenital ptosis. The patient has got a levator action of, let's say, 8 millimeters or 9 millimeters, who's got moderate ptosis. And that is when you will try to include the molars also, because you want the effect of the molars resection also. You want to do a molarectomy along with the LPS resection. But in aponeurotic ptosis, usually there's only a pathology of detachment of the aponeurosis to the tarsal plate. The patient's got very good levator action. So you really don't need to touch the molars at all. Because introp, when you touch the molars, usually it bleeds badly. And sometimes you need to cauterize. You have to you have to be careful that you don't damage underlying cornea when you're cauterizing, all that. So when you touch molars, you have to be a little bit more careful. So do it in congenital ptosis, where you want the combined effect of a levator with a molars resection.
Yeah, and also what Usha madam said, that just addressing the central suture, which is basically the main suture for elevation. The rest of the medial and the lateral sutures are basically for the contouring.
Exactly, correct.
Yeah. So do you put 3 sutures for all your levator cases?
Yeah, I used to take 3 before, but now I find even 2 is enough. You take the central one and one laterally. But again, I usually rely more on introp checking of the contour. I take sutures and then I check how it is. If I feel there's a slight medial droop, I just put one more also. So what you just need to titrate where you're placing the suture. So the central one, if you place it slightly to the medially to the apex, then you just need one more, slightly medial to the pupillary central line. You can just put one laterally. So most important is check on the table how the lid contour looks. If you have any doubt, if you're doing it at GA and all, it makes no harm in putting 3. Like you said, the central one is the most important. That is going to lift the lid and give the apical contour. The lateral ones just, it's sort of a security so that you don't have a lateral or medial droop, which will have a contour problem. So that again, patients are very concerned if they have not a good contour, that's a big issue for them. So no harm in placing 3 sutures. Just make sure you don't tighten it too much or don't aggressively place it very high on the levator so that you get a overcorrection on the sides.
We are short of time, so
I just have a question, Dr. Pratibha. Can I pop it?
Yeah. Okay, sir.
Question to Dr. Sindel and to the panel. Do you have any tips for keeping the lid tarsal show?
Pardon me?
The lid platform, the tarsal platform.
Yeah.
You did a very excellent surgical job, and you have very good lid height. But sometimes there's an asymmetry in the lid platform.
Yeah, exactly. Yeah, that is depends on where you form the. You mean the crease? Is it the lid crease height?
The lid crease height.
Lid crease height, yeah.
But the show of the tarsal platform.
Yeah, exactly. To show of the tarsal plate will depend on the where the lid crease you're going to place, because that is where the tarsals will start showing. So it's again very important to check the lid crease height of the other eye. So you have to match it with the other eye. So suppose it's going to be a patient of from the east of India, they'll have almost like a mongoloid lid crease, which will be very low. Whereas if it's going to be in the central and down south, you'll have almost normal Indian-looking eyes. Whereas east, they'll have slightly sort of the mongoloid type of lid crease, which is very low placed. So you have to be careful. All patients, you can't put it at the same height. Always check the other eye and try to match it. You just measure what is the lid crease height, and then that depends on where you put the incision more than the lid crease form. The initial incision is the most important, because that is where you can form the crease. So the initial incision is the most important, because that's where your lid crease will actually fall. So you see the height of the other eye lid crease and then measure and place your incision.
Thank you. Very valid point indeed. Initially, we were just looking at lid height, but increasingly, I'm looking at symmetry of tarsal platform nowadays. Thank you for your invaluable inputs. Thanks, Sendil.
Thank you.
Very good talk, Sendil, as usual.
Thank you, sir. Thank you.
Thank you, sir, and thank you for the discussions and inputs from seniors. So now we have Dr. Dayakar. So Dr. Dayakar has started his ophthalmology training from Royal Victoria Infirmary and currently practicing in Aravind Eye Hospital, Pondicherry. And his areas of interest are lid, lacrimal, and orbital disorders. We welcome you, sir, to give your talk on frontalis link. Dayakar, sir.
Yeah, thank you, Dr. Pratibha. And can I share
Yes,
the
share your slides. We are seeing your WhatsApp, sir.
Can you see my PowerPoint?
No.
They're seeing your delicious sambar vada.
WhatsApp.
Oh my God.
It is still not seen, sir. You have to share the slides.
Share the slides. Yes, I'm coming for it. Like 1 second.
I like the shuttle club, Dayakar.
And why did you leave SKD without the sambar vade, Dayakar? You have to make up with him today.
It seems to be more interesting.
Students are out, Dayakar.
Who's SKD?
The slides now, at least? No?
No, Dayakar. Don't show us another screen, please.
Ma'am, can I ask you a question, ma'am? If there is I'm Dr. Yogeshwari.
Yes, madam.
Ma'am, if there is a conjunctival prolapse, how the slide is on? How do you manage in aponeurotic advancement?
Again, this conjunctival prolapse actually it has to be graded, and it's only because of the excessive dissection that we would have done probably. So I'll just give you the tips that I follow, but may not be practically applicable for everybody. A simple reconformer just to reposition sometimes would be adequate. And then you probably can use mattress sutras to release the prolapse. But you can just start with a very simple reconformer. I don't know how many of you have tried this, but this does help in very minimal prolapse. And then in severe cases, probably you'll have to do a mattress suture.
Thank you, ma'am.
Can you see my slides now, madam?
Yes, sir. Yes, sir. Please start, sir.
I thank Dr. Pratibha Devi and the TNOA for giving me this opportunity. My topic is frontalis sling. So as the indications are severe ptosis with a poor levator function, most commonly seen in simple congenital ptosis and the synkinetic ptosis associated with aberrant regeneration, blepharophimosis syndrome. And very rarely, some patient may request in CPEO and myasthenia. On patient request, we can do it. Congenital ptosis, as the name indicates, is present at the birth and within few years of life. Then the types of and etiology, most commonly developmental weakness of the LPS. It may be divided into simple or associated with superior rectus weakness or part of blepharophimosis syndrome or synkinetic ptosis. As the name indicates, it is a failure of migration of developmental muscular sequelae, unilateral or bilateral. In bilateral cases, there will be a chin lift, an absent upper lip crease, and poor levator function is the characteristic findings. The superior rectus palsy present, it's because it's a close embryological association with the levator, which both of them develop in the same sheet. Compensatory chin elevation in bilateral cases, as mentioned before. The refractive errors are the most common cause for amblyopia. It's not the ptosis, but we should keep in mind, we should do the refraction for all the cases. So this is the case of superior rectus palsy with the ptosis. If you do the ptosis correction or sling in these cases, it looked odd. So first correct the superior rectus or double elevator palsy correction should be done first. The blepharophimosis syndrome, as the name says, it's a horizontal orbital fissure narrowing. It is divided in types, type 1 and type 2, depending on the ovarian failure and genetic transmission. Dr. Usha madam has done a lot of research and published a lot of papers on the genetic transmission. That is the associated telecanthus We should not be confused with telecanthus with the hypertelorism and epicanthus inversus. When the poorly developed nasal bridge and the hypoplasia of the superior orbital rings are the secondary features of this syndrome. So usually the parents got them in the initial days of the birth, then they show them. So depending on the ptosis, we can go for a staged approach or a single approach. We can go. There is an excellent video by Santosh Hanover. We can see in a YouTube. The ptosis, the Marcus-Gunn jaw winking phenomena. It is the mandibular division of fifth nerve, which is misdirected to connected to the levator. The retraction of the ptotic lid and congenital stimulation of the ipsilateral pterygoid muscle. Less common stimuli like a winking of the jaw protrusion causes the retraction. Jaw winking does not improve with the age as a patient try to mask it. This is the rare jaw winking. You can see bilateral. So the indications like severe ptosis with a poor LPS function. If it's a sudden onset, the adults comes, please rule out myasthenia. Don't jump to the sling. The materials used most commonly are the fascia lata. It's a gold standard, but the silicone rod is the most commonly used. I use the silicone RO sling. I don't have a financial interest, but there is a paper published in Ophthalmology in 2008 by Lee et al. There is not much difference between a fascia lata or a silicone rod. Ethibone suture is also been used before, but nowadays nobody uses it. It's a video.
Hello. Sorry, ma'am.
Yeah. Can you see as a marking medial limbus and lateral limbus? I use the Fox pentagon method, and then the lateral canthus and the medial canthus in the brow area incision and the forehead mark. And then after that, we lift it up and see the contour, how the contour look like. When the forehead incision is made, then subcutaneous pocket is created. Look for then the RO sling is used. It's a silicone rod. The pre-pierced needles, the silicone sleeve will be there. You pass to the superior point, so it will be easy to pass. While passing, this step you should be careful not to damage the lacrimal gland and not to damage the globe. Always use the lid guard. Then while passing this stage, like the medial part is the most difficult part to pass through, because of deep, steep nose. So you should bend the needle, then come out. Once you come out, pass the needle through the silicone sleeve. Then adjust the lid margin, superior MRD1. We will leave it at the MRD1 at a superior limbus, because sometimes it might sags down. Bury it and suture it. If it is a GA cases, then some of the pre-op and post-op pictures. This is a pre-op and this is a post-op pictures. So the bilateral cases, the day one post-op, there will be edema, there will be a swelling. So you should warn the parents beforehand so that they'll be really apprehensive. So the next most common scenario is like in the exam, they'll ask you the Marcus-Gunn jaw winking with a congenital ptosis. How do you manage? This is a levator dissection with a LPS sling. That is the answer you should tell. So similar to that previous, this is a. So this we can see the Marcus-Gunn jaw winking phenomena. Similar to the previous case, we will mark. So the LPS, the lid crease incision is made, as Senthil is mentioned before, like cutting the septum. So we'll left it open, we'll leave it open to the pre-aponeurotic fat. It's a white yellow glistening fat you can see. That is the indicator of pre-aponeurotic fat. So that indicates, as when I was a beginner, I was very scary about the LPS. I'm able to find the LPS or not. Then after that, remove the LPS. Part of LPS I will remove. Then identify, you can see the cornea. Then it is a complete resection. Then pass the sling. That's Akshay Gopinath Nair, my next speaker. He's got an open sling technique. You can see his YouTube video. It's very good, but I use a closed sling. See, like we can adjust the lid height, then the lid contour, then leave it exactly in the superior limbus. Then leave it longer, little bit longer, the tube, silicone rod, so that future adjustments, if you need, we can leave it a little bit longer. So leave the cornea with a ointment, the lubrication. Then the frost suture is very important because most of the cases will be in the GA. So this is the pre-op and post-op pictures. So this is instantaneous results. The complications of frontal surgery, lag ophthalmos, always counsel the parents before about the lag ophthalmos for a few years. Otherwise, the parents will not be very happy. When lid lag, you tell the child that when they look down, there will be a lid lag. The contour abnormality, as Senthil was talking extensively about the contour abnormalities, the frontal sling also not immune to contour abnormalities. There might be some cases, although we take precautions. Suture site infection is very dangerous. Once a suture site infection happens, the sling will not retain, it will come out. Whatever we do, we have to remove the sling and then do it again. Under correction, the parents will complain that it looks similar to the previous and then it is not good. But it is under correction is always better than the over correction because the over correction causes the exposure. This is the over correction. Then this is the sling extrusion. Once the sling comes out like this, we cannot do anything. We have to take out the sling and then put the new sling after some time. This is the exposure keratopathy. This is very dangerous. Once the exposure keratopathy happens, then we cannot do anything. So like we have to adjust the sling. Otherwise, the patient will develop a corneal ulcer and the patient will perforate. To take home message, preoperative evaluation, mainly to confirm the diagnosis. And then not to do the sling in a myasthenia patients or wrong indications. Indications in the mainly in a simple congenital ptosis or Marcus Gunn jaw winking phenomena. Associated congenital ptosis like a double elevator palsy or a splint should be corrected first before jumping to the frontal sling. Always counsel the parents regarding the lag ophthalmos or exposure. Thank you.
Thank you, sir. It was a nice presentation with a lot of pictures and good videos. Lakshmi ma'am, your comments?
There was talk about the extreme medial horn and the lateral horn, right? We actually don't excise the horn. We go towards the medial horn and towards the lateral horn. I think as far as Dayakar's talk is concerned, he's explained all the steps beautifully again, like Senthil. I don't know whether sling will be the first option, and he showed about 4 or 5 millimeters of excision, or maybe a little more because the levator would have shriveled in Marcus Gunn. I don't know how much exactly he excised it. And in the same sitting, he is doing the sling surgery, right?
Yes.
So I really don't know whether the Marcus Gunn can be fully abated in this, whether it will fully go off. And what age is this undertaken? Is it early on? Because if the vision is good, I think we can afford to wait. Dayakar, can you please explain on that? Ptosis with Marcus Gunn, jaw winking.
Yes, madam. Ptosis with Marcus Gunn jaw winking, we will wait till the child goes to school. When the child is conscious in the school, they say like the child is not able to attend the school because of the consciousness. Then we will proceed with the.
What about amblyopia? Because usually there won't be much of
usually in amblyopia will not be there, madam, because there will not be any ptosis or correction or the pupil is not covered. There will not be any amblyopia.
So how much did you excise Dayakar?
Usually 2 to 3 millimeters, madam. We remove
That's all. Will that be enough?
We will not completely remove it, madam.
That means it will still be stuck there to the conjunctiva and you don't release it until the vitnals, is it? Before you excise it?
We will not remove till until the vitnals, madam.
How does it help then?
It's giving good result, madam. If you want, I can show the video once again that last.
No, it's okay. Let us know next talk or something about your long-term results, or please post it in the group for the benefit of all. Because I'm under the impression that how much ever you excise, even if you excise and wait for 2-3 months, which we are doing in the past 2 decades back, some amount of jaw winking will remain.
Very, very minimal, madam. But most of the cases will be very satisfied.
So only 3 millimeters you're excising. That means it is just from the surface of the upper height of the tarsal plate, you're taking out. So you're not even releasing its connections from the molars.
Yes, madam. No,
conjunctiva and molars.
Nothing.
Okay.
Aparna ma'am?
Yeah. So, Dr. Dayakar, so you have not disinserted the levator, is it?
Yes,
what we usually do in Marcus Gunn, we totally disinsert so that it sulks down in the cavity, as Madam said, Lakshmi Madam said, and then we go ahead in the same procedure with the sling.
Yes.
So,
Aparna, early on we were waiting for 2-3 months.
Okay,
and the ptosis would have worsened. That was when the doubts of the parents showed up, and then the jaw winking also remained, and then we decided we'll give it up and teach. I decided to teach them some exercise and wait until they were 12
Yeah.
or 13. I hardly do this procedure anymore. So
Right.
Dayakar, I'm really, because usually when you disinsert itself, it shrivels a little
Shrivels a
bit.
little
It rolls
bit,
up like a cigarette.
Yes, yes.
So I'm just wondering whether it is a little more Dayakar. Are you very sure it's only 3 millimeters?
Yes, madam, 100%. Like we are doing good and our results are really
No,
good.
not doubting. I'm just asking for the
No, madam,
clarification.
I can understand. Thank you, madam.
Dr. Pratibha, can I make a point?
Yes, sir. Yes, sir.
Yeah, actually, Dayakar, that's a very nice video. What Dr. Lakshmi Mahesh madam was also alluding to, what I do is I don't cut the levator aponeurosis at all from the tarsal plate. I go above the Wicknell's ligament and we directly isolate the levator muscle, belly of the levator muscle, and then it will be like a rectus muscle. It will be like something like a thick medial rectus. So that we isolate with 2 muscle hooks, lift it up nicely, we fulgurate it and cut it. I learned this technique from Dr. Sampath from UK, and he has been doing it for the last 20-25 years. And I do only that. And this gives very good results because the levator aponeurosis, no, how much ever you try to distance it from the tarsal plate, it will definitely be stuck somewhere. Even if one strand is stuck, you will be amazed at how much the body can regenerate. Like what madam was saying, again, the phenomenon will come. So if you cut the muscle belly directly, and you should not only cut it, you have to completely, what they say is fulgurate it. That is, you have to completely cauterize it for 2, 3 or 4 millimeters and then cut it and allow that both ends to retract inside the orbit. If you do that, that gives very good results and you don't have to disinsert the aponeurosis at all. But
what about superior rectus? Superior rectus will be underneath it.
Yeah, that you have to put a tag suture. First, you have to put a 4-0 muscle onto the superior rectus. And before you cut, when you hold the levator muscle, you have to pull that the superior rectus tag suture and make sure you're not holding the superior rectus also. So before you start, you have to, like when you do for a cataract surgery, you have to just put a bridal suture, superior rectus bridal suture. So that once you
That's
isolate
a very,
it.
very nice suggestions, and I think I have never done this. I'll keep this in mind. Can Dayakar, you answer Aparna's question fully, please?
Yes, madam. Yes, Dr. Aparna, I missed your question. Can you repeat the question again, please?
No, so I was wondering, Dr. Dayakar, like you don't disinsert the muscle. You have just resected a part of levator.
Yes, like a disinsert means like we are not separating the only tarsus, upper part of tarsus, we are separating and then we are removing it. Not the
so how will it,
not lateral horn or medial horn, or
but
not.
it will still contribute to the Marcus Gunn phenomena post-op.
Yes, it's not completely like if it is 100%, like 80 to 90% is gone. Only very minimal movement is there, but it's like patients are happy with that.
Okay. The other point I wanted to discuss was about managing lid crease in these cases when you are doing when you are not doing an open sky technique, like when you are not giving a lid crease, but you are doing a closed pentagon technique. Sometimes we see fresh post-ops or even that gets sustained on for a later post-op period. There is a bulkiness over the lid area, which looks like a lid edema, which is actually not a lid edema, which you're just trying to mechanically pull over the lid. So how do you deal with such patients, number one? And number two, what the Watsky sleeve that you have, do you suture it? Do you first suture and then put the sleeve and then kind of put it in the tunnel?
Yes, very good question. 2 questions are very good. Like the first thing is, like I have seen many people previous like Santosh Anawat sir or Akshay Gopinath Nair or other people videos. Like the Watsky sleeve, they suture it, but in our setup, like we won't suture it. It's very good, and it is not like slippage, or we have not noticed any slippage till then. That is the one. And the second is like the bulkiness is there in the initial few months. It will be there. Like the edema will be there because of the bunching up. All that will be there. But as the time goes on, by 1 year follow-up, everything will be perfectly all right. That bunchiness.
Does it have the symmetry for the other eye? Because what I see, the pre-tarsal show is a little more closer in the operated eye as compared to the normal eye. So how do you address that?
It is not like a LPS resection where there's a one month post-op, they'll be all right, but it will take few months to come back normal. It will come back, but no need of any extra medicines or nothing is needed. It will come back in a few months' time, that the edema will disappear.
Do you feel open technique will be better for forming the lid crease? Because then you'll have an open show of the tarsus also, where you can actually place your sling.
The open better, but I'm used with this one, and this works well with my hands.
Okay.
Okay, thank you.
I
Thank
don't know
you.
what exactly the answer is.
Shahid has an important point. He has raised it in the chat. He says they don't even do any extubation. They straight away go for a sling.
Yes,
That's
madam.
an important observation. I think it'll be interesting to know what exactly they do and what they're more than what they do. It's quite clear what they do, but how are the long-term results?
Thank you for the wonderful learning points from all of you. Now we have the next speaker, Dr. P.M. Arvind, sir. So, Dr. Arvind, sir, has done his surgical training in Arvind Eye Hospital and Moran Eye Center and is currently the director of Samara Eye Hospital. Is very soft-spoken and excellent surgeon. We look forward to hear from you, sir.
Very good afternoon. Thank you, Tnoa. Thank you, Dr. Mohan Rajan, sir, Dr. Pratibha, and Dr. Atek for organizing this program. I want to share my screen. Yes. Can you see my screen? And
Not yet, sir.
Can you see my presentation now? Is my presentation visible?
No, it's not seen, Arvind. We still can't see it.
It says screen sharing has failed.
Have you opened your presentation first on
Yeah,
your
presentation is open. I can actually see it on my screen.
For want of time, can we have one questions by from the panelists each for the subsequent presentations, or?
No. Pratibha will go to the next speaker.
Yeah.
Come back to Arvind.
Okay. Okay. So we have Dr. Shruti Tara. Next, to speak about common ectropion surgeries. She has been trained in Singapore under Dr. Gangadhar Sundar and currently in Shankara, Coimbatore. And she has many publications and presentations. And we look forward to hear from you, ma'am, on surgeries on ectropion. Shruti, ma'am? Yeah.
Yeah.
So my screen is visible, right?
Yes, ma'am.
Yeah, I'll start. Thank you, Pratibha and Tnoa for having me here. In the next couple of slides, I'll just go through my experience, my minimal experience in correction of the entropion. So I would mostly concentrate on the involutional and the spastic entropion, and if time permits, probably we'll go into the upper lid as well. So basically, as we all know, horizontal lid laxity, that is the canthal tendons, dehiscence of the lower eyelid retractors, and overriding of the preseptal or pretarsal orbicularis and enophthalmos, like in orbital fat atrophy, are the major causes. So sometimes or most of the times, we'll have to address all of these to get the optimal results and preventing recurrence. So it is needless to say that a good preoperative workup is very essential, and we have to be aware of the systemic ailment, if any, because we have to think in terms of stopping the blood thinners and take necessary consultations with the physicians, and also to make a note if there is any previous surgery so that we can tweak our current surgeries to enhance the result. So now the involutional entropion, I would just go into the small step surgeries first. Suppose if the patient is unfit for surgery and we have other things in need, like a mature cataract or something like that, then probably we would just think in terms of suture rotation. So this is done by taking a stitch at the fornix and hoping that we have tacked the retractors. This is blind procedure done with a double arm suture. Another one, and you exit below the lash line. And tighten this just to get that minimal ectropion. So there is a recurrence in this 50% in 2 years. So this just generally doesn't work very well in my hands. So Jones is something that we commonly do, because this addresses the retractors as well as when you tighten the lateral canthus as well. So an incision, after giving the local block, traction stitch is placed, and 4 millimeters is marked below the lash line. Orbicularis is separated to expose the lower border of the tarsus. And you go down the suborbicularis plane to reach the septum. So septum is something which is multi-layered and glistening. So once you incise that, what lies below that would be the retractors. So you can separate it both anteriorly and posteriorly. Now, how we identify this is you ask the patient to look . So when the patient looks down, that moves down. So that is the retractors. And now that is sutured to the lower border of the tarsus. So we can take 2 or 3 stitches along the entire length of the tarsal plate. And the lid tightening is also done. This I won't stress now because I have a separate video on that. So this would be the suture tightening. The orbicularis is closed and the skin is closed appropriately. So if necessary, very, very minimal skin is taken out. If there is excess in the old, we can, very minimal, so that we don't have ectropion later. So this would be the post-operative appearance. Suture suspension or suture canthoplasty. This I picked it up from Dr. Ganga and I found it quite useful, especially if it is very mild laxity. So knot is placed to prevent slippage. I use Vicryl itself because I feel that there is fibrosis there instead of proline which can slip. A small scratch incision is made on the tarsus at the lateral most point, and the tarsal plate is hitched to the suture, and then you come out to the incision that you have placed onto the periosteum. So you include the periosteum and exit. So you place it a little higher like how we do in the lateral tarsal strip. The second needle also is, it enters in the same point as the first needle. The knot is small enough and it goes in and it prevents the slippage. And that is tightened and the skin is closed. So the lateral tarsal strip, this is a pretty old video of mine. So this was not done for ectropion, but for the sake of showing how the lateral tarsal strip is done, I would show this. Is everything seen there? Or is it?
Yes.
Okay. A lateral tarsal strip is created by making an incision after doing a canthotomy cantholysis. A lateral tarsal strip is made by make an incision at the gray line. A strip is created by making an incision below the lateral tarsus, and the gray line is excised. Now I trimmed it, so I don't know if everything is seen. And the conjunctival end is debrided, and this strip of tarsus that you have created is hitched to the orbital rim. Is it seen?
I think it's getting cut in the
Yeah.
lower part.
Okay, wait. I will just exit this and later show this video. Yeah. So now extra part of the skin is exposed, and a lateral canthus is formed. So the lateral canthus formation is very important by taking a stitch from the gray line to gray line. So that forms a sharp canthus, and the rest of it is the orbicularis and skin is closed. We'll see if I can go back if there is time. And this is how it looks, but if all these bunching would eventually even out. So Botox also can be given patients if, if they're not fit for surgery. 2.5 units per 0.1 cc is given into the lower part of the orbicularis. So that gives a temporary eversion. V's and quickers, I don't generally do it because it doesn't work in my hands at all. Maybe I haven't learned it well, so I don't do it. This was something that I wanted to show was a spastic entropion, a patient with Steven Johnson. He had done a lot of shopping everywhere, and many times Botox was given, everting stitch was given, and all the time it would help him for a couple of months, and then again it would recur. So I thought maybe we could just do myectomy. So a subincision, an incision was made below the lash line, and the orbicularis, the preseptal orbicularis, was dissected. A little by little, and the entire preseptal and the preorbicularis, pretarsal orbicularis was dissected off and removed. And this was how he was. And his mother said after many years, he finally opened his eyes. And it's quite gratifying sometimes. So terminal tarsal rotation is done for the upper eyelid entropion. An incision is marked below the upper border of the tarsus. You go deep down till you see the pink molars. This was again done for a patient with Steven Johnson only. He had severe entropion. A stitch is taken from the undersurface of the tarsus, leaving the conjunctiva underneath, and it is sutured under the upper tarsal border, the incision, the tarsus on the upper edge of the incision. So the terminal tarsus is rotated. So this gives them good relief. So tarsal wedge resection is done again for the upper eyelid if there is adequate tarsal height. So I'm just marking where exactly the entropion is. He had mostly on the lateral aspect. So after injecting anesthesia, incision is placed and you go up to the level of the tarsus, and the tarsus is bared. A wedge is created in the tarsus. So and the edges of the wedge are approximated. So it gives an eversion. And the orbicularis is also, maybe you can hitch the orbicularis also to the upper border of the tarsus, only the lower part of the orbicularis. And you can see the eversion that is achieved on the table. And the skin is closed. Thank you.
Thank you, ma'am. There was a wonderful collection of videos on ectropia.
Sorry, the lateral tarsal strip, what happened was I cropped because the patient's face was seen and the lower part is completely gone.
I think Varsha will also be presenting on lateral tarsal strip.
Ah, great. Yeah. So then I think that should complete it.
Yes, ma'am. Okay. So comments from the panelists, please. Lakshmi ma'am, Aparna ma'am, any comments, any suggestions?
Very, very nicely presented, each of them with wonderful examples. Shruti, congratulations. That case where you showed myectomy, what was the indication? Was it Stevens-Johnson?
Stevens-Johnson syndrome. His cornea was completely, he had, it was because of the Stevens-Johnson syndrome. The entire lower lid was inverted in. He had a mucous membrane grafting done elsewhere, both upper lid and lower eyelid. But I think because of the spastic thing, that entire lower lid was turned in.
But
So
what about the severe dryness now, which will set in further?
we have
Because
to aggressively lubricate him.
reflex is going to be weak.
Yes, so we are aggressively lubricating him. But what happened was now, because the entire lid was also inside, along with the skin, that was abrading more. So now with the lubrication, he's quite fine. But I think the cornea guys are planning to take it further now.
So would you have considered the corneal correction first, or
No,
the
ma'am,
aggressive
because
lubrication initially?
It just maybe because the entire lid was inside, even the lashes and the tarsus and the skin, everything was inside. So what the cornea consultant said was like, even if we do anything for the cornea, with this lid turning inside, we will not be able to do much. So they wanted me to correct the lid and then go ahead.
So you did only the myectomy, but you
I
didn't
did only the
excise even a
myectomy.
millimeter of the skin.
Yes, ma'am.
then
Leaving
it's
about 3
okay.
millimeters from the lash margin, I made a incision, and then the pre-tarsal and preseptal orbicularis, I removed it entirely, the lower lid.
Because he's a young patient, that's why I was wondering. Okay.
Yes.
Thank you.
Okay. We'll move on to the... yes,
can I make some
ma'am.
comment? Shruti, for the upper lid, you showed tarsal wedge resection for that case. Could you have considered going in for a gray line split?
Yes,
local
we could have.
with the anterior lamellar reposition?
Lamellar recession could have, but I didn't consider that as mainly because his ectropion was only on the lateral half. So I didn't wanted to bring the entire upper eyelid, recessed up. So I just tackled only that part.
Okay.
And it was bilateral. So I didn't want to do the recession bilaterally for both eyelids. And it was very symmetrically there on both the sides and just on the lateral aspect.
Okay. And for the other patient that you did in orbicularis myectomy, so you didn't address the retractors, right? That was
No,
the same.
I did not. I did not. I did not.
So what was the cause of his entropion? Like the retractors
I think it
were
was
not.
mainly the enrolling was because of the spastic thing. He used to go on squeezing his eyes, so that whole thing was rolling in. Retractors, I could have probably recessed it. This is
Since
holding.
you were going in for a myomectomy that time, could you have just
could have recessed it as well? But he's holding well for the last 6 months, so I hope that he holds well as further.
Thank you.
Okay. So we are running short of time. We'll can we move on to the next speaker? Arvind sir, are you ready with your presentation?
Presentation was always ready. The
Sorry,
technical part is what is having an issue. I've been advised to play the presentation without going into slideshow mode. So that's the good part about oculoplastic surgeons. We always adapt according to the situation. So I'm back here. Good afternoon. Can you see my slides?
Yes, sir.
Yes.
I'm going to only move them one by one. So Dr. Sendil has handled all the old age doses. Dr. Dayakar has handled all the congenital ones. that leads us to the selfie-conscious younger generation, which is now very wary about even the slightest asymmetry that they have in their eyelids. And more, I'm sure you're seeing patients like these who send you photographs on WhatsApp about how different their eyelids look. So this is a small tool that you can have in your armamentarium to handle very minimal doses in very cosmetically aware patients. The procedure is called Muller's muscle conjunctival resection. I'm going to briefly talk about the muscle, how to select your ideal patient, spend some more time about the surgical techniques, and then talk about its outcomes. So the Muller's muscle is a small, smooth muscle buried underneath the levator aponeurosis. It's unique that it's smooth and it has a sympathetic innervation. It's responsible for the involuntary elevation of the upper lid to about 2 to 3 millimeters. So when you wake up all sleepy and groggy in the morning, that's because your Muller's hasn't woken up. And once it comes into action, the mild ptosis also goes away. It originates on the posterior aspect of the levator and it gets inserted into the superior tarsal margin. Now, the theory is that the Muller's acts like a muscle spindle and generates a stretch reflex for the levator. And when you alter the stretch reflex, shortening the Muller, the levator tone improves. Now, the key for this procedure is obviously a good patient selection. Choose your patients with mild ptosis, 2 millimeters or less, who have good to excellent levator action. Always establish the onset. Always ask them to bring all their photographs from their childhood to make sure you're not having a congenital ptosis on your hands. Rule out synkinesis. Also rule out mechanical causes like contact lenses and papillary conjunctivitis, which could mimic mechanical mild ptosis. The phenylephrine test is always the gold standard for assessing your patients, not just to see if they're suitable for the surgery, but also to simulate what their surgical outcome will be. Since phenylephrine is no longer available commercially, you can use tropicamide plus. It has phenylephrine as a component. So your dilating drops can be applied in the ptotic eye. You wait for 5 to 10 minutes, come back, and then recheck the patient. So this is a patient who we put only 1 drop of tropicamide plus in the right eye, and you can see her result 10 minutes later. Now the technique itself was described by Putterman and Purist. It was Muller's muscle conjunctival resection. It is a much better improvement from the Fasinella servate itself. The Putterman's clamp derives its name from its originator. Now, unable to run the videos, I'm going to do a photo session. The anesthesia is local. You're going to inject lignocaine with adrenaline into the subconjunctival space after inverting the lid. Raise a small bleb and do this at least 5 to 10 minutes before the procedure so that you have a good avascular space in your surgical field. Invert the lid with traction suture. Use a 4-0 silk or a ethylene suture to nicely put traction on the lid margin. Use a Demar lid retractor to nicely expose the conjunctiva here. And we are planning for an 8 millimeter resection, which usually gives you a 2 millimeter correction. And since the lid is folded over, a 4 millimeter marking will give you an 8 millimeter resection. So mark the 4 millimeter on the free conjunctiva, leave at least a millimeter above the superior margin of the tarsus to avoid including the tarsus into your cutting area. So the tarsus traction sutures are put and you clamp the Muller's muscle along with the conjunctiva in this procedure. Now, once you've done that, you clamp on both sides. The Putterman clamp is unavailable. You can use 2 curved artery forceps to clamp the Muller's with the conjunctiva, leaving enough margin from the tarsal plate to pass your suture and also be able to cut it through without harming the tarsal plate. Once you've passed a continuous suture with 6-0 Vicryl underneath the 2 retractors, you can resect the Muller's and the conjunctiva together and close the defect. Now, key point in actual closure is how you hide the last suture knot, because that alone will be on the conjunctival surface. So I prefer taking a small subconjunctival bite and tying the knot well under the conjunctival opening so that you have a tight knot which goes into the conjunctiva, and you trim the edges flush with the knot, leaving no chance for corneal irritation. An alternative is to bring the suture ends out through the lid onto the skin side and then suture them on the skin side of the eyelid. But that, of course, is going to leave a mark on these eyelids. And we would like to see these patients do much better than see a suture on their outside. A nomogram is suggested by the original paper, but I feel that doing an 8mm resection gives you very predictable results in most of the well-selected patients. I've now moved on to doing conjunctival sparing Muller's resection because I found that I was excising too much of conjunctiva when that is not the actual reason for the pathology itself. So now I open the conjunctiva much beyond the tarsal plate, expose the Muller's separated from the levators, the white line which you can see, and then resect and suture the remaining resected Muller's margin to the tarsal plate. These are some of the patient outcomes. Pre-op mild ptosis, a week after surgery, a little mild edema on the upper lid, and about 4 weeks later, they are quite well recovered. And as I have progressed, I can see that the results of surgery also get better earlier on. You don't actually have to wait 4 weeks. The recovery is much quicker. This is another patient here. Now the results, of course, get good lid height and symmetry, very predictable. It's very easy to do in a good oculoplastic surgeon's hands. The cosmesis is excellent. Obviously, there's no scar. There is hardly any variability after the recovery. The patients don't have ptosis early in the morning and late in the evening. Recovery is rapid. And unlike fasciculus avata, and this is what I like the best, the tarsus is not compromised. The complications, if you've not paid attention to the conjunctival surface, you can have a corneal irritation or an abrasion, even a corneal ulcer. So mind you can use liberal lubrication post-surgery, or to be on the safer side, you can put a bandage contact lens on the cornea to keep it protected. Now, overcorrection is hardly an issue. It hardly happens, but undercorrections are definitely possible. And I've had to do external levator resection for 2 of these patients who seem to do well on tropicamide, the phenylephrine test, but didn't do very well with the Muller's resection. The obvious limitation is the lid crease and the tarsal show. These adjustments are not possible. And pretty much whatever result you get is standardized. There is not much of tempering with the lid height that you can do intraoperatively. So that's a very short presentation for you. I'm sorry I wasn't able to put on the video and had a lot of technical issues, but now I'm open for questions. Thank you.
Thank you for the short and sweet presentation, sir. Questions from the panelists or comments, ma'am?
A very nice presentation, because this surgery I have not done so far in the last 31 years. I don't know how to do it. So first of all, before I ask the question, do you take any suture? Arvind, do you suture at all, or you just gently cauterize and leave it there on the posterior aspect? Or you take buried knots if you have to suture?
I always suture, madam. The suture is what actually pulls the Muller's into traction. Again, the misnomer is it's not a Mullerectomy.
So how do you suture? Muller's
excision. What I used to do was I used to pass the suture through the conjunctiva and involve the Muller's. And at the end, I used to just suture it tight like a purse string. So the Muller's automatically shrinks along with the conjunctiva. But now I'm a little more confident in dissecting the conjunctiva and separating the Muller's. So I pass mattress sutures, just like the levator aponeurosis. I pass it through the Muller's, bring it out on the tarsal plate, just at the superior margin. You don't have to expose too much of the tarsus.
What suture are you using? Vicryl, is it?
Yes, 60 or 80 vicryl.
But then you have still a small raw wound which will rub on the cornea, right? So that's why you want to use PCL?
Yes.
Or is it a watertight wound?
The Muller's sutures now I put as a mattress suture, madam. For the conjunctiva, I suture it, and then the end knot. I take a concealed suture so that the sutures are not exposed on the conjunctiva. And the trick is the knot itself. You have to bury the knot somewhere, anchor it on the subconjunctival or the tarsal plate so that that doesn't get exposed. That is taken care of Usually,
So,
there's not
okay, so what is your indication for this surgery? Young people, you said, what function they should have? Do you have a rule of the thumb where you're going to take out this much of molars for this particular amount of ptosis? So it is mild ptosis, am I right? Positive
No, ma'am.
phenylephrine test. What's the rule of the thumb? Or how do you select your patients?
These patients should have excellent response in the phenylephrine test, madam. If you can see a visible response, and I always take photographs before and after the procedure and show it to the patient. I always tell them that this is how the result is going to be after the surgery. So if the photograph shows a dramatic response in phenylephrine, they will do very well in the surgery also. And there is not much in terms of moderating the lid height, which is possible. Though this nomogram says 6 millimeters, 8 millimeters, and 12 millimeters, I have not found a lot of variation with the lid height by doing any extra or lesser resection. It's always one or none, all or none.
Some technical issues. Sai, sir. Okay.
Was I audible? Or
Yeah, you are audible, sir.
Never works. Am I audible?
Yes, ma'am.
Hello? You are audible.
Okay.
Yeah.
So I think it will be nice, Arvind, if you can show us a proper video next time, and also your series, how many you have done and what is your long-term follow-up. It will be interesting to note, but I think you're doing a good number of these cases. Thank you.
Frankly, madam, I've done about a dozen in the last 8 years.
A dozen is a great big number.
It is, but it's still not as well as the external levator approach. The number
I know that, but it's still
3 to 1. So I would definitely like to see. The good part is the young people, it offers very good predictable results. If we select our patients well, then we can offer them hassle-free surgery.
Because the only thing is, you yourself mentioned the crease formation. So young people are very finicky and they're very, very difficult to please. So that crease also has to be perfect, right? So please let us know more about what you're doing. Yeah.
Thank you, madam.
Ma'am, ma'am, can I just add one thing? I think Arvind,
Please.
great presentation. I have now expanded this to include even congenital ptosis patients with mild ptosis, regardless of phenylephrine status. And there are papers that show that although phenylephrine is, textbook wise, we should be choosing aponeurotic ptosis patients who are phenylephrine positive. Congenital ptosis patients, regardless of phenylephrine test status, also give a good response because essentially you're shortening the posterior lamella, which lifts up the lid by 2 millimeters.
I'm happy you brought that point because actually I've done 2 congenital cases where we were not very sure about the phenylephrine test, but they did really well. But again, I think it's about understanding the Muller's, how it works as a synaptic reflex improver. Not exactly shortening, but probably improves the levator tone, just like when you pull an arm to do a good knee reflex. The shortening of the Muller's probably elicits a better levator response. That's probably the better way to understand it.
That's nice. That's very good. And I'm really grateful to you, Akshay, and all the youngsters for bringing out new ideas. Please, teach us more, because it's time that bandicoots like me don't keep on saying what works for us. We need to learn from you all. Thank you.
Very kind of you. Thank you.
Thank you. Aparna?
Yeah. Arvind, nice talk. So few pointers. One is there are people who are late responders to phenylephrine test. So very, very important when we are actually considering to have a positive phenylephrine test for us to kind of schedule our patients for the surgery. Sometimes we just ignore the time period taken for the patient to become phenylephrine positive. So there are some 10% of population who will kind of show positivity after 10 minutes. So just a pointer that we need to consider. And beautifully that you showed that, your later stages, you are kind of saving the conjunctiva. that will kind of address the loss of goblet cells also, conjunctival goblet cells, which would kind of in the later part of the treatment may cause dryness in our patients. So that's a very good technique I think we should follow. So first we are just kind of giving up the tarsus, and now we have actually given up on dissecting the conjunctiva also. So we are actually working only with the molars, which I think will solve the purpose.
So what's the maximum amount of molars we can do it, Aparna, all of you who are doing it?
Madam, as per the literature,
because the muscle as such visibility is about 8 millimeters, no?
Yes,
maximum 10.
Maximum
10.
Yeah.
It's not goes up. It doesn't go up to the vidnals. So if the aponeurosis goes 15 millimeters, this doesn't go up to that.
Yeah. So if you consider the textbook logarithms and all, it says that excision up to 8 is okay.
8 okay.
May lead to some undercorrections in some patients. And Guyben had a series of patients who showed that they had 40% of undercorrection for excising 8 millimeter. So they went ahead and did a 9.5 millimeter resection, I mean mularectomy, which gave them good results. So anywhere from 8 to 9 to 9.5 millimeter should work.
Thank you. Thank you.
Yeah.
Thank you for the learning points. And now we move on to the next speaker, Dr. Varsha. She's an excellent oculoplastic surgeon who's soft-spoken and humble. She makes excellent presentations and has won many awards for her presentations and has won many awards for her papers. And she's currently working as a consultant of orbit oculoplasty in SN. Over to you, Varsha. Varsha?
Yeah, yes, ma'am. Are my slides visible?
Yes, Varsha.
Yeah, okay. Very good afternoon to all. At the offset, I would like to thank Dr. Pratibha and the entire TNOA team for giving me this wonderful opportunity. I'll be talking about common ectropion surgeries. Ectropion is a single problem with
You're not very clear.
I should say, and imperative to identify the underlying etiology, be it Downs, blepharophimosis.
Varsha, your signal is not good. I'm not able to hear properly.
It may be secondary as
is it clear for others?
In a setting.
No, Pratibha, all of us are having problems.
Okay.
Yeah, yes, all of us.
Varsha, your internet is not stable. We are not able to hear you properly.
Basic underlying pathology.
I think she's not getting to know that. Can your technical team please tell her or somebody?
Yeah, I'll tell her. Varsha? Meanwhile,
we'll go to the next speaker, Pratibha.
We'll look at Akshay's video. I have it with me. I'll share it with you.
Pratibha, you'll have to share the audio also of it.
Okay, so
share the screen.
Okay, 1 second. 1 second, I'm sorry.
Sure.
Hello. I'm so sorry. I think I just got disconnected.
Varsha, you have to stop sharing. Your internet was not stable. So
okay.
I'm not able to take Akshay's. Or you can start presenting.
Okay. Till when did you see, ma'am? You couldn't see the entire. Okay, I'll start presenting. I'm so sorry about it. It was working perfectly fine till now. Yes. Am I audible? Is it? Yeah.
Yes, Varsha. Yeah.
We are unable to hear her though.
Hello.
Yeah, continue.
We're not able to hear.
I think the internet connection is very poor.
Yes. We'll go to the next speaker, Pratibha, and then come back. We're already very late.
I'm sorry.
Can you hear
Yeah.
me now?
The audio is not very good. We can see the
We'll
slides.
come back to you, Varsha. Yeah, I think Akshay should present, and then we already gone past 2 o'clock. And normally, you know, for after 2 hours, people don't stay in the webinars.
This is Akshay's video. Is the audio also
for
heard?
this invitation to speak on lower lid blepharoplasty.
Is the audio heard?
Yeah, clearly heard.
The important aspect of any surgery is the pre-surgery assessment. Here, the aim of this, of course, is to know who is a good candidate for a blepharoplasty and who is not. Now, typically when a patient presents to us with under-eye bags, one of the things we ask him or her to do is to look upwards. The appearance of these under-eye bags tends to worsen on upgaze, which confirms that this is lower lid fat collapse. Now, this is because the inferior rectus and the lower lid retractors are relaxing in upgaze because the superior rectus is contracting. As a result, the tone of the orbicularis, the tone of the septum, and the fat pads reduces, allowing it to bulge out. Conversely, when they look down, the lower lid retractors and the inferior rectors are contracting, pushing the fat pads back in position, and therefore the appearance improves on downgaze. Now, this is seen in young and middle-aged patients, but in the elderly population, in addition to the worsening on upgaze, what we also see is that in downgaze, there is the excess skin that rolls up and is seen as a separate layer. This is indicated that they will benefit from a transcutaneous approach. Additionally, in primary gaze, if you see some amount of lower lid inferior scleral show, this is also indicative that perhaps a lid tightening procedure may also help these patients.
Okay, ma'am. Yeah.
Red flags for any assessment in blepharoplasty, upper or lower, are ptosis, malar mounds, excess skin, fluid bags, and active thyroid eye disease. Now, another concept that we should be familiar is the hills versus valleys concept. Now, the patient on the left, you can see that there is a prominent fat prolapse in the lower lid, which essentially is the conceptual hill. The hill is the bulge that is seen in the lower lid. Compare that to the patient on the right, where the more prominent feature is the deep lower lid or the tear trough hollow, which corresponds to a valley. Now, the end objective is to have a smooth lid-cheek junction, which means that in the patient on the left, you need to flatten the hill, and the patient on the right, you need to fill the valley. As you would expect, in upgaze, the fat bags appear worse, confirming that these are fat bags and they need to be flattened out. Therefore, the patient candidate one, a fat excision, transcutaneous blepharoplasty to smoothen the lid cheek junction, and the patient on the right underwent hyaluronic acid filler injection to the tear trough hollow, giving us a very, very acceptable outcome in both patients. I'll quickly go over a video of conjunctival blepharoplasty. The most important part are the three landmarks, which is the three fat bags, the medial, the middle, and the lateral. Between the median and the middle lies an important structure, the inferior oblique muscle, which we need to be cognizant about. Local anesthesia, in my cases, I prefer to give intraorbital, followed by cutaneous infiltration. And just before the conjunctival incision is made, a little ballooning of the conjunctiva with local anesthetic. 3 to 4 millimeters below the tarsus using a radiofrequency monopolar cautery probe, I make an incision along the entire length of the lid, and directly you have access into the fat pads. Another procedure which is useful to do is gentle pressure over the globe downwards, pushing the globe down, which causes the fat pads to bulge.
I'll try again, just pray it works.
Fat pads, you need to be gentle and tease the fat out and not go hunting for the fat into the orbit. Before excision, inject some amount of local anesthetic and then use minimal cautery such that there is no bleeder left behind that retracts into the orbit. As you can see, you need to be very gentle in teasing the fat out. Based on a case-to-case basis, you may either choose to do fat excision medially or fat transposition under the periosteum. Once the fat pads are excised in this case, we need to be very particular about the lateral fat pads that can be difficult to access. The wound is closed with 6-vicryl interrupted sutures, which dissolve in about 4 to 6 weeks. The result is that you are able to achieve safe and reproducible outcomes in patients who come with lower lid fat prolapse. This is across genders, not with women, but also men. This young patient had only a medial prominence, and therefore I preferred to go with a fat transposition in him rather than a fat excision. Now, transcutaneous blepharoplasty is a procedure where you need to address the excess skin along with the fat bulge. So here, it's important to know how much fat needs to be excised. So what I try to do is simulate a cutaneous excision. So by pinching the amount of skin that needs to be excised, here you can see that by pinching this much skin, the lower lid position has moved. So if I were to excise this much skin, I would cause a lid malposition. Now I go ahead and try again, and I do a conservative skin pinch this time without altering the lower lid position. Therefore, this much skin can be safely excised without causing ectropia. Ideally, I'd like to do this pinch test in the patient with sitting up. Anyways, once the marking is done, local infiltrative anesthesia is given. I prefer to use a blade rather than a cautery because it tends to scar easily or scar well in patients where I use a blade. Once you have access into the septa, you can see and identify each of the fat pads individually. Now here you can see the medial, the middle, and the lateral fat pads. Again, inject before cutting or excising. Now laterally, when you have excised all the fat, raise the skin up completely such that you have a slightly pulled up vector. Now you check for any excess skin, excess fat that bulges up. Now this is what I was speaking about. You want to drape the skin out. It's like tightening effect. The wound is closed in layers. You can see at 4 weeks, there is a good outcome in this patient. Complications that we need to be aware of are hematomas, subciliary scars, especially if you've used the cautery a lot. Prefer to use the blade over the radiofrequency cautery and close in layers. Lid retraction and ectropion are very commonly seen, and therefore if you see a patient in the early post-operative phase with lid retraction or ectropion that is evolving, go in and address that earlier rather than later, because you don't want to affect the functional outcomes in these patients. Adjunct procedures, you can customize these procedures in patients as and when you want. Now, this patient who came with lower lid fat prolapse for a blepharoplasty underwent a fat excision blepharoplasty. She had a good outcome, but she felt there was a slight skeletonization, which meant that she felt there was a little bony appearance. We augmented this with 0.5 cc on either side with hyaluronic acid gel injection or filler to smoothen the lid cheek junction. As you can see, the before and after are telltale, and the patient was very satisfied with this customized blepharoplasty with filler injection. So therefore, a thorough assessment is important. A customized management helps. One size doesn't fit all. You need to be very good in your assessment to decide whether a transconjunctival versus a transcutaneous or a filler injection helps. Early recognition and management of complications is always good. Thank you once again.
It was a very nice presentation, Akshay. Only thing, this fat removal, the teaching was I have learned to clamp and then cut. You have always injected and then cut. Is it not necessary to clamp? Direct injection and cutting would suffice?
Yeah, I think any technique that you're comfortable with is okay. Just blindly cutting may not be recommended. So the other thing that you can also do in lieu of clamping is to hold the fat pad with your forceps at the base and cauterize the tip of the forceps, which essentially then cauterizes the blood vessel in the stalk of the fat pad. So that can also be done. I think in the video you could see me doing that as well. Just that you want to cauterize it or use the cautery and not cut blindly, such that if there is a blood vessel that is oozing, it oozes and then retracts back into the orbit, and then you may end up with a early post-operative hematoma.
A few quick comments from the panelists, and then we
very nice presentation, Akshay. Excellent. How often do you have to give hyaluronic acid, and when do you have to repeat it? Now, you showed a very beautiful result where the patient was not happy with the hollow and you gave filler. How did you have to repeat this filler in this patient or any other patient?
So typically, I have had very few cases where we've had to inject. Mainly that is because of probably overzealous fat excision, where fat trimming and possibly repositioning would have helped, where you can open up the periosteum and take push it under the periosteum and take a stage suture outwards, such that you fill the teardrop hollow with fat intraoperatively. But in cases where there is a slight, skeletonization, you can either opt for a filler, which hyaluronic acid in the teardrop area.
How long does this filler stay?
So Bellator or Juvederm lasts for between 12 to 18 months, 15 months on an average, after which, and because it's not a off the cliff sudden drop in the, it doesn't go immediately at 15 months switch off. Patients are able to appreciate a gradual, a loss of effect, which most of them tend to be okay with, because at the end of the day, the before and after are still improved. So I've not
you
had
mean
to
to say
them yet.
very rarely you have to give a second injection?
Right, ma'am. Right, ma'am.
Okay. Thank you.
Shall we move on to
Thank you,
Varsha's presentation?
Can you hear me now?
Yes, Varsha.
We can hear you, Asha.
Yes, yes. Thank you so much. Thank you for your patience. I guess the lunchtime is nearing. I'll try to make it quick. So the topic is common ectropion surgeries. Ectropion is a single problem with multiple solutions. So it is imperative to know the underlying etiology, be it congenital, cicatrial, involutional, paralytic, blepharophimosis, Downs, urebliphoron, and others. It may be secondary as well in a setting of congenital ichthyosis, and this requires skin grafting. Here are a few cases with blepharophimosis syndrome who have undergone a full thickness skin graft prior to ptosis correction, and they're doing pretty okay. Here is a short video of the technique of full thickness skin graft. An incision is made 2 millimeters below the lid margin. The graft location is marked according to the defect size.
Audio is not clear, Varsha.
The most common location contralateral upper lid skin, the pre and post auricular and the supraclavicular area. We usually use a template to mark the size of the graft. And following this, we administer the local anesthesia. It prevents the bleeding, as we also use adrenaline along with it. And then a careful dissection and harvest.
Sorry, Varsha's signal was not good, I guess. Is she disconnected now?
Disconnected, yeah.
Okay, I think the signal was bad. Shall I ask her to send it to me and present it, or what should I do?
I think we should, don't mind.
Okay.
I think we are already at 2:30 now, almost.
I'm sorry, sir, for the delay.
Yeah. Varsha is not able to log in.
Okay.
Yeah, I'll request Sindhil to give the vote of thanks.
Okay, sir.
Okay. Thank you, sir.
Just check up. Check up.
So do you want me to give the vote of thanks now?
No, just check up.
Check up with Varsha. Okay.
Okay.
Pratibha, you'll check up with Varsha.
I'm calling her.
Yeah. I think she's got some internet issues. So audio is not clear.
Audio is not clear. Yeah.
Akshay, are you there?
Akshay has left, I think.
Oh, okay.
I think I have to thank Dr. Mohan for his patience. I think very, very few people, I don't think, I don't know whether anybody else like Dr. Mohan stays back until the very end. He goes through, he's there for every presentation. So with big encouragement. Thank you so much, sir.
Lots of learning, Lakshmi. I learned a lot. In fact, 2 weeks
Yeah,
back
you're
also, there was
extremely, yeah, I should really appreciate you, sir.
no. Actually, we have found that any webinar which goes beyond 2 hours, people log out. So that's
No, not for that I'm telling. What I'm saying is, Poduvave, even the earlier one.
All meetings till the end, he'll be there.
I'm there till the end.
Even the speakers log out and go, but he will be there till the end.
Yes.
It's a big inspiration.
Yes, sir.
Thank you so much, sir.
The amount of energy he has, I think, very few people have. Anyway, thank you,
Dr. Varsha. Is she going to speak now, or shall we?
No, Usha madam actually is having some other talk in Ramat.
No, Dr. Varsha, is she going to speak?
Her signal is bad. So
Okay, so we will.
Okay, so we'll give the vote of thanks.
Yeah.
Okay, sir. So at the outset, I'd like to thank our president, Dr. Mohan Rajan, and the TNOA team for coming up with this excellent concept. And I'd like to thank Dr. Pratibha, who did a great job organizing the whole meeting, and with Dr. Atik. I'd like to thank all the speakers and panelists, most of whom are extremely busy, both from our state and from neighboring states, who have taken valuable time off on a Sunday to come and join with us. A lot of learning points they have shared with us, or most of them are very senior consultants, and it's always a pleasure to have them with us. And last but not the least, I'd like to thank Sai Numerotech and Hoya Ophthalmicus for supporting this educational program. And I'd like to thank all the speakers, panelists, and the audience which have for attending this meeting. Thank you all once again. Thank you.
Thank you, sir.
Thank you.
Thanks a lot.
Thank you all.
Yeah.
Thank you for the patience.
Thank you,
Stay tuned for
Pratibha.
more.
Thank you, Mohan, sir.
Thank you, sir. Thank you. We'll meet up soon. Thank you.
Bye.
Thanks,
Susan.
Pratibha.
Bye, sir. Bye.
Thank you, ma'am.
Thanks, Mohan, sir.
Thank you all.